depending on how or what they're faced with, if they can still move around. Some of them can't even do their jobs anymore. What else can they do? One needs to offer them other options. And we keep saying we need to educate our patients. It really helps. When an individual knows what they're faced with and the complications that can come if they don't take their drugs and what they can prevent when they do it, they would adhere. It's not easy, but people can't. You know what's like taking drugs for life? It's not easy. Even anti-malaria, some of us, we don't finish it for 3 days. Just 3 days is a problem. Then you're telling someone to take drugs for life. It's not easy. But if you're able to explain to them, let them understand the implications, they would do it. Then let them also know the signs to look out for. Not just buying drugs over the counter because it's readily available. Once there's any problem, they need to come back to the hospital. Some of these medications we give them, oh, I'm coughing, they go and take macrolides, or that's azithromycin. All of that is available. But this causes QT prolongation, which they are prone to arrhythmias. So some of these things, if they don't come to the hospital, they wouldn't know. They just take drugs anyhow, and then they have worsening of symptoms, and they can't explain why. So if they have any problem, any medical condition, they should come back to the hospital for proper evaluation and treatment. And then low sodium diet. Low sodium diet, it also helps them. They should cut down their sodium intake. Also, there are different ways the heart failure patients can present, and we need to look out for these things. Sometimes they could come in just, okay, the straightforward ones, they have the symptoms we talked about. We can investigate them. We do natriuretic peptide is markedly elevated. We treat. There are times when they might come in congested. So your focus at that point in time is to direct them as much as possible while you're gradually introducing the 4 major pillars of our medications that we've all talked about. There are times when they will come in pulmonary edema, their chest is congested. They might not even have pedal edema or tender hepatomegaly, just the chest that is congested. So you know your focus at that point in time, especially with elevated blood pressure, is to sort out the diuresis. So you just need to individualize your care for that patient based on the presentation. And then when they come in cardiogenic shock, that is not when we are thinking of putting Yoperio. That's not when we are thinking of doing all the beta blockers or MRAs. What you want to do now is you want to give your inotropes to see how you can support them. Sometimes they have to be admitted in the ICU for mechanical circulatory support. So it's still based on individualizing your care based on what the patient presents with. But look out for these things. If it's cardiogenic shock, know that your target at that point in time is to give inotropes to see how you can uptitrate their blood pressure before you start giving drugs that can be of help in heart failure. So going through the devices quickly, we need to know that these devices are available and know when this patient needs it so that you can refer them appropriately if you don't have it in your center. Pacemakers, we use it most of the time for patients that have symptomatic bradycardia or AV block, 3rd degree, or Morbus type 2. Once, they might not present in heart failure, but if they do present in heart failure, we know that, yes, this is available and they can be offered. We also do implantation, ICDs, CRTs. Before we go into that, let us present a case so that you understand when to prescribe or recommend these devices.
Okay, so we have an 80-year-old man with diabetes, hypertension for over 20 years. Also has a background history of chronic kidney disease and heart failure. He presented to our emergency department with worsening of his heart failure symptoms. So you already knew he had heart failure. So the predominant symptoms were dyspnea with autopnea and early satiety. So on physical examination, when he presented, there was significant bilateral pit and pedal edema extending to the knee, fine bibassal crepitations on chest examination. His N-terminal pro-BNP was markedly elevated as displayed. Urinalysis showed a plus of protein. On his electrolyte urea and creatinine, his creatinine was at 1.5 milligram per deciliter, which is elevated. His ECG and Holter ECG revealed polymorphic ventricular complexes, low grades 3 to 4. His echo showed an ejection fraction of 22%. He subsequently had a coronary angiography, which revealed normal coronary arteries. So this was his ECG on presentation and the ER.
So for emphasis, this is our own patient that we are managing. So it's a live case. It's not something we just hooked up. This is a patient we are managing. And at the end of the day, we had to insert an ICD for this patient. And along the line, because this patient was on guideline-directed medical therapy, was on all the medications required, but was still symptomatic, we then had to do place an ICD for this patient. And somewhere along the line, because this was done early part of this year, somewhere along the line, the patient had a syncopal attack. Just for some few seconds, the wife said, just noticed he was unresponsive, and then later on, he was able to talk. And we had to interrogate the ICD and realized that he actually had a ventricular fibrillation at that point in time when it happened, and he had a shock from the ICD. And that was just life-saving for him, and that was what helped him. And until now, we're still seeing him on follow-up basis, and he's doing well. So you can understand that it just didn't stop at just medical therapy. There was need for ICD. I can imagine if we didn't fix that ICD, what would have happened to him? So going further, we've talked about the indications of pacemakers. You have the slides later on, so you can go through it. But generally, symptomatic bradycardia, as we mentioned earlier on. And then we talked about the need for ICD. For ICD, before you talk about putting a device for this patient, the patient should be on medical therapy for at least 3 months. And it's still symptomatic. And the EF is still less than 35%. And you know that you expect the patient's life to still be prolonged for more than 1 year. So it's not somebody that you know that for whatever reason has other comorbidities that is going to die within less than 1 year that you are talking about. This is somebody that still have a prolonged lifespan. EF is still less than 35%, still symptomatic, despite being on guideline-directed medical therapy. Then, and it's in NYHA 2-3, then consider ICD. We can go through this later on. Then there's room for CRT, especially when the QRS complex is more than 130 milliseconds, much more when it's more than 150. The patient is still symptomatic. EF less than 35%, still on guideline-directed medical therapy. Emphasis on the patient should be on guideline medical therapy because that is very important. And it's still symptomatic. You do your ECG, QRS complex the QRS complex is very broad. Then consider CRT. We offer it in cardio care. Our patients are doing well on this medication, on this device therapy alongside their guideline-directed medical therapy. This is a table to just let us know when to request for ICD or CRT for our patients. So this is also like, this is the ESC guidelines. We can also look at it later on when we have the slides. So please, I would like us to go back again to the very first question because we didn't get the answer. And it's so important because that's the whole idea of this presentation. Diagnosis. We need to make appropriate diagnosis so that we can know how to treat appropriately. I'm hoping that we now have a clearer picture of what heart failure is all about. So we should get this question now. So please, can we go to the poll and answer this? I think this was the previous one, or is it? Okay, all right. Please, are we there, or do we need assistance? Are we there? Are we there? Yeah. Oh, we need to refresh. But it's changing slowly. Please, I want to make sure that people are not still going with the first. Oh, okay, okay, okay. So please, can somebody just tell us what the answer is? Okay, okay, I feel better. Oh, but we're not yet there, Sha. You can't be 50-50. Oh, BVF is biventricular failure. Sorry. Secondary to hypertensive heart disease, precipitated by severely elevated blood pressure. I had to abbreviate it because it will occupy the whole screen. Okay, thank you very much. So in conclusion, we all now know what heart failure is all about, and I'm hoping that we can make appropriate diagnosis, looking out for etiology, precipitants, and knowing that this patient also would benefit from device care when needed. So heart failure is a chronic condition. Good history and physical examination is very important because that's the only way we would know what it is and be able to address it. And don't forget a guideline-directed medical therapy. It's important. This is not time for methyl dopa or all the rest. Those ones that we need are of benefits. We've talked about the SGLT2 inhibitors. We've talked about the MRAs, our RAS blockers, that's the ACE inhibitors, ARBs, or Uperio, that's the ANI, and beta blockers. And it's a multidisciplinary approach that should be taken. Thank you very much.
So we'll take a few questions. How many people saw digoxin here? Yes, anybody see digoxin? Or Sloke? Yes? Did they make a mistake? Come, you have not gone on, there are still questions. Or what? Or Nat B? Or Celgevity? I mean, sorry. I hope the pharmaceutical companies are not here. Anybody see any of those things? No. Okay, so you can see that the approach to heart failure has changed significantly. Are there questions? Dr. Inowa is here. Dr. Inowa is one of our consultant cardiologists at CardioCare. Yes, please. And there's somebody at the back too, okay?
Okay, thank you very much for the presentation.
ICD means implantable cardioverter defibrillator. Implantable cardioverter defibrillator, which we put in just the same way we put in like a pacemaker under the skin and we connect it to the heart. And it picks up those things that will have caused sudden death and then shocks the person. So that was an example of somebody that will have died if he did not have a device in. And one of the most common indications is when the ejection fraction is less than 35%, despite adequate medical therapy. You typically should have those patients. That's one of the most common. You typically should have that in there to prevent primarily sudden cardiac death. Now, if somebody has had a cardiac arrest too, and they're in heart failure and you successfully resuscitated them, they need to also have the ICD for secondary prevention. So those are the things, those are the most common reasons. So please, if you successfully say I successfully resuscitated the person, great. Now refer them so that we can put in the ICD. Before we go ahead, I want to recognize the CMD of FMC Kefi, one of our great teachers and senior colleagues, Dr. Yahya Adamu. Welcome, sir. He's here. He's coming and put a device during the Interventional Cardiology Symposium. He was there. We did a device together. I really appreciate you, sir, and I'm very happy he came. Okay, so questions briefly, and then.
Okay, so thank you very much for the presentation. Good afternoon, everyone. I'm Chijoke Otiba, a physiotherapist currently interning at National Hospital. So what you said about, it's clear that this is a you take a multidisciplinary approach to this, and it's been common practice not to usually get referrals for cases like this on time. So I wanted to know, to you, what is the best practice for referral to physical therapy, exercise rehabilitation programs? How early should you refer, or how early should you invite that aspect, that wing of the multidisciplinary team for management? Thank you.
Okay, thanks for the question. Okay, as I keep saying, you just need to individualize your patients because it depends on the NYHA classification they present with. Some might be so dyspneic. That's not the person you are saying, oh, jog or walk and all the rest. But as soon as they are out of that acute phase, as soon as they're out of the acute phase, they are no longer breathless. Because sometimes they will even tell you, even to go to the bathroom is a problem, to take their bath To dress up is a problem. Any slight walk is a problem. But once they're out of that acute phase, with your medications appropriately given, then you can commence the exercise because it's needed. Lifestyle modification is important. Physiotherapy is important. You need to start exercise as soon as they can tolerate it. So it depends on the patient. That will determine what next you want to do. But just know that these are the things you should offer so that when the time comes, you know what next to do.
So once the patient is NYK2, preferably, but sometimes even from NYK3, that is that they can, at least at rest, they should not be breathless. Now, the physical therapy or any form of physical exertion should be symptom limited, meaning that anytime the patient feels symptoms, you must stop and rest. So what typically will happen is that it will take a long time. So you do small, the patient feels, you will wait. The patient gets recovered, then you will now do a little bit. Another way to determine the patients that will qualify is by their 6-minute walk test. So when patients have heart failure, anywhere you are is free. Walking is free, Abi. You can ask the patient to walk for 6 minutes and you measure the distance that they can walk. Typically, you should have pre-measured the ground and then they can walk back and front. Put chairs on the way, on the step, so that once they get tired, they can sit down and rest. Measure the 6-minute time. Typically, if I'm not mistaken, it's 25 to 30 meters. Once they can do 25, 30 meters and above, I'll confirm it again. Then you think, number one, they have a better prognosis, and number two, you should start considering. So from NYK3. Finally, it is also important that the physical therapists also understand the heart failure. So that is where there has always been a problem. If the physical therapist does not understand heart failure, then they start doing stroke rehabilitation. Okay, so that becomes a problem. Now, one of the ways we also do in cardio care is that your treadmill, the treadmill you use for your stress ECG, there is a program for rehabilitation, in which case you put the electrodes, you watch the ECG, and we will learn about ECG. You should monitor the ECG during that period and then be able to identify if there are issues that therapy is inappropriate for them. So those are the things. And then finally, you must get the clearance from the cardiologist at when to start. But the earlier you start physical therapy, the better for quality of life, the better for occupational rehabilitation. We have loads of patients working at different levels. But once we are able to get on these things, yes, physical therapy is really very low. For cardiac rehabilitation generally, it's very low. And we have very, very few. I don't know any physiotherapist that has specialized in cardiac rehabilitation. Post-surgery, after we put a stent, after we have a device, there are very few. Of course, this is what we are doing. So by the time we can have some of them, we can now work together, teach, and then they can now work with us. Thank you. Somebody had a question?
Yeah.
Somebody had a question? Okay.
I am Ajia Grace, nurse from Federal Medical Center, Kefi. We have a patient that was diagnosed of having hypertension about 30 years ago and was not really regular on her medication. In 2007, she came down with CCF, secondary to hypertensive heart disease. That's about 15 years ago. Since then, she has been regular on her drugs and her clinic visits. That's her appointment. But up till now, she's on diuresis, that's furosemide and spironolactone. She's on telmisartan and other anticoagulants, clopidogrel. But she's still having pulmonary congestion and paroxysmal nocturnal dyspnea, severe one, as at now. And she's dry because she's not having edema. In fact, she's even complaining of symptoms that's of dehydration because she complains of dry mouth and throat, but she's still having pulmonary congestion and severe paroxysmal nocturnal dyspnea. What else can we do to help this patient improve her condition? Thank you.
Okay, thanks for the question. First of all, I would recommend refer her to cardio care.
Dr. Shidali is in FMC Kefi, yes, if I remember. So Dr. Shidali, if you see the patient, Dr. Shidali is my very good friend.
Okay, because it's very important to know precisely what medications she's taking, at what dose, titrating it up to a tolerable dose for her. following the guideline-directed medical therapy. Then we can repeat our echo. Let's know what it is. Is the EF still less than 35%? And then, if that is so, then does she qualify for ICD, which we just talked about, that's implantable cardiac defibrillator? Does she qualify for that? We do it and we can offer it to her. Or does she qualify for CRT, depending on what she presents with and what the ECG is like. If the QRS complex is broad and we see that she'll benefit from CRT, why not we'll fix that for her? So that's why I said refer her to us and let's sort her out.
So there are, from the drugs you called, so did you remember the presentation she said? What other drugs is that patient not on? Yes? Who can remember? The patient is not on SGLT2 inhibitors. The patient is not on ANI. The patient is not on beta blockers. No, it's on spironolactone, she said. It's on spironolactone, yes. So the patient is not on SGLT inhibitors. The patient is not on ANIs. The patient is not on beta blockers. You cannot really win without those drugs. The evidence is glaring. Now, I will put a caveat. Those drugs are not cheap. Okay? So it's also, and so they are less likely to be in smaller towns. So the pharmaceutical companies typically leave them in Abuja, Lagos. So it may be difficult for you to find it in some areas. I will not lie to you. Okay, we have some of them that are around and that we present, I think Novartis, Basic, that have some generic ones that can be used. But that patient needs to be optimized. Those drugs must come in. And sometimes it's very difficult to have those drugs come in at the patient at home. You need to admit that patient and start adding the drugs properly and gradually. Now, if you have done all of that and the patient is still remaining, you should begin to consider whether that patient will qualify for biventricular pacing, that's CRT. In the CRT, we put a lead into the right ventricle, a lead into the left ventricle, and have both ventricles, well, not directly to the left ventricle, but through the coronary sinus. And have both ventricles, harness both their power together to push the heart better. And the patient will get a lot of improvement. So first thing first, the therapy needs to be optimized. And ANIs are not there. What are the ANIs? The drug typically is called, is sacubitril valsartan. Sacubitril valsartan. So if you ask me, the telmisartan should go, and she'll replace with sacubitril valsartan. So if you ask Dr. Shidali, he will do that. Then beta blockers must come in. Beta blockers must come in. Then the SGLT inhibitors also, empagliflozin, should come in, and they are available. Typically, you start with 10 milligrams, check the blood pressure, repeat the echo like she has said, do all those other things. But if you don't add those things, you are unlikely to get very good outcome. Okay, so furosemide is not enough. Furosemide is not enough. Drying up the patient is not enough. As soon as you dry that patient, the next thing you should have the opportunity to do is to put your beta blocker. Now, number two, if you've dried the patient and you continue wiping the patient with furosemide, chances are you are going to cause hyponatremia. Hyponatremia is another reason why the heart will not recover well. Okay, so when the patient is dry, you may need to cut down the furosemide a bit and monitor those electrolytes. If the hyponatremia is there, you will walk or you will do everything. The patient will not get better. Okay? And then hyponatremia and heart failure is a serious question. If somebody has a question here. So I advise that for the nurses and the other people in the hall, I know clinics in the public hospitals are very busy. There are some patients that must see Oga. Then there are the other ones that just came with 140/90. They should not come and waste to get Oga's time. So those patients must see the main person. That patient must be managed at specialist level.
Thank you for your presentation and contribution. What was the dividing line between acute and chronic? Is there a time frame? Is there a time frame or something? Acute and chronic heart failure classification. Thank you. Then for the ICDs, what is the range, the price range we should tell patients? Because they will definitely ask you in a public hospital, doctor, how much? So what do we tell them? Thank you.
Okay, the question is acute and chronic heart failure. So for starters, heart failure is chronic. Okay? So heart failure is chronic. What we mean by acute heart failure is just an acute decompensation. So heart failure by definition is a chronic disease. It's invariably progressive. So you cannot say somebody has heart failure now and they come and give testimony that now they are cured. No, it's not one of those kind of things. It's invariably progressive in a lot of cases. The exception may be peripartal cardiomyopathy. Okay? So when we say acute heart failure, what we are saying is that this patient now has NYHA class 4. Something precipitated. The blood pressure went very high. They had an arrhythmia. They are now breathless. They had to come to the hospital. You have to give all of that. That's what we mean by acute heart failure. Those are the ones you're not trying to do physiotherapy for. You're not trying to, play around with. So that's what we mean by the acute heart failure. But generally, heart failure is chronic by definition. The second question is the cost of ICDs. So there are two. The only ones we use now, at least in cardio care, are the MRI compatible ICDs. That's what we prefer. And there are two types, single chamber and dual chamber. Now, the ICD can become a pacemaker itself. It can also defibrillate. It can cardiovert. So it can do so many things. So an ICD is more expensive than a regular pacemaker because it can do all of that. It depends now whether you are choosing a single chamber or a double chamber. Okay, so if you think that this patient may develop an AV block in future, or you can see some of those signs, you should put a dual chamber. Okay, and you think that there are other issues, you should put a dual chamber. If you are just putting for primary prevention, then a single chamber will be okay. Single chamber pacemaker should, I'm not sure, maybe around 2 to 3 million. Double chamber should be around 4 to 5 million. Something about that. Okay. Now, can we do without it? Maybe. But what will have happened will have been, for that patient that we talked about, will have been BID, Abby. Yeah, so we know from the studies from Europe that there is a significant difference in quantity of life and quality of life, as much as 6 to 7 years difference. So that person is coming for follow-up today. If there's a man we put on Friday, by Sunday he had a shock. You can imagine, what would have been. So you should just wait, offer the patients the best. Otherwise, they travel actually. They travel and they say, what kind of, why didn't you offer them this? So offer the patients the best. The ones that cannot afford it, optimize their medical therapy, and then one day they will afford it. Now we also have a program with University of Michigan and an NGO in the UK where we offer reconditioned pacemakers and ICDs. So reused ICDs. Okay, so that is a lot cheaper, maybe almost 60%, 70% cheaper than the normal one. So it can be very low for that one. So if patient cannot afford it, or they are willing, they can't get, so it is reconditioned. The ICD was used by somebody else. It was sent back to the factory, re-sterilized, and the battery was pumped up back to almost the same level, and we are running a study currently, back to the same level, and then we can use it for people that can't afford it. Sometimes 750,000, 100, 1 million, we put it. If they can't afford it, at least it's there and it works normally. Okay. Almost all of us are using second-hand cars. Yes, please. If you are using a new car, I'm not sure you are a doctor.
Hello.
Yes,
Hello,
please.
sir.
Now what our next one will bring a banker to come and talk to us about the effect of cardiovascular health. Please, can somebody give him a mic? Okay, somebody else. Oh, sorry.
Good day, sir. My question is, I can recall some time ago there was a guideline that was put in place advising against the use of beta blockers in acute decompensated heart failure. The reason being that their beta blockers are negatively inotropic and chronotropic, so would further worsen the cardiac output of the patient. So for a patient who had acute decompensated heart failure, which was the trigger for going into CCF, I would like to ask, are there any specific clinical and or laboratory parameters that we can use to guide our initiation of beta blockers in this therapy, since beta blockers have a known mortality and morbidity benefits in the management of heart failure? Thank you.
Okay, thanks for the question. Initially, yes, beta blockers were said not to be used in heart failure. But now, based on the ESC 2021, the latest guideline, you can use it, but there's a caveat. It should be used once the patient is off the acute phase, once you dried up the patient, you can use it. Or except there are other indications for the beta blocker. If this patient is coming with atrial fibrillation and heart failure, you need to slow down the heart because that will worsen the heart failure. So that is another indication for the use of beta blocker, even in heart failure. If the patient has other arrhythmias, like you do an Holter and all the rest, and you can see the patient has other arrhythmias and would benefit from beta blocker, yes, you can. But in the acute phase, when the patient comes congested and all the rest, that is not when you want to start the beta blockers. But along the line, before the patient is discharged, that means patient is now stable, then you can commence your beta blockers, because we all know now that beta blockers is effective. It helps reduce morbidity and mortality, and the sooner you introduce it, the better for the patient.
Let me just add, beta blocker does not include propranolol, because sometimes when we finish, we now say people who prescribe propranolol. No. Or atenolol either. Please, that's not what we mean by beta blockers in heart failure. So if you come around patients that are with heart failure and are on those drugs, please stop them. They will worsen outcome. For those ones that when you want to start, typically make sure they are euvolemic. That is, you should have dried them up significantly. If they were on beta blockers before they decompensated, do not stop. Do not stop. You may reduce the dose as much as possible, except the other contraindications. But while they are there, once you have been able to get them dry a little bit, downgrade them from NYHA 4, maybe to NYHA 3, you can start at a low dose. Start always low. So you typically start from the lowest dose. So if you're starting bisoprolol, 1.25 or 2.5 milligrams, and you grow slowly. If you're doing carvedilol, 3.125, and then you grow slowly. If you are doing metoprolol, 25 milligrams, metoprolol succinate, not metoprolol tartrate. Please remember that. Metoprolol succinate. Okay, sometimes when you prescribe metoprolol, they go to the pharmacy gives them whatever it is. Metoprolol succinate, not metoprolol tartrate. Succinate is the long-acting, slow-acting one. That's the one that has more benefit. Nebivolol is also good. So, carvedilol, bisoprolol, metoprolol, nebivolol. So, BC never enters a car, Abi, meta, 3 times. All right, do we understand? Remember those drugs: BC, bisoprolol, carvedilol, metoprolol, and metoprolol succinate, and which one have I mentioned? Nebivolol. So please, let's remember those drugs. Those are the beta blockers we're talking about. And you start at the lowest dose, and you gradually up-titrate. You up-titrate to the maximum tolerable dose. So if you start small and you say, okay, they are now beta blockers, they are fine. Like the patient we're talking about from the hospital that you talked about. What you do, you must keep on increasing till you get to the maximum tolerable dose. For carvedilol, it can get as much as 50 milligrams twice a day, or 25 milligrams twice a day. For metoprolol, you should get to 200 milligrams. For bisoprolol, you should get to 10. Okay, so those are you must keep on increasing them till you get to the maximum tolerable dose, how much they can tolerate. Okay, I hope that helps to answer that question. So the patient comes in, sweating everywhere. Don't say, we learned from ACS. It's not here. It's not here. Yes? Any other questions? We'll take one last question.
Good afternoon, sir. Good afternoon, ma. My question is actually a hypothetical scenario. Let's say we have a patient who has heart failure and diabetes as a comorbidity, and they come down with a hyperglycemic emergency. Considering the fact that one of the principles of management involves fluid resuscitation, how would we go about it, knowing that they have heart failure?
Those are the sweet cases, Abi. Those are the cases that separate men from boys. Okay, so typically what we do is, this is one of the cases you should not manage without a specialist. Number one, I think I should just say that up front. You should not manage a specialist. You should not manage in the open ward. You should try as much as possible to manage in an ICU setting. And the reason is simple. You typically have to put in a central venous line and measure their central venous pressure. You use that central venous pressure to help you guide fluid therapy so that you know when you are going too much or too little, but you must give fluids. You must still give those fluids, but it must now be guarded. And you use your central venous pressure to be able to guard. Now, many people don't have central venous pressure monitoring. Abi, what do they do? That is where specialists looking at and listening to the chest. So you try and measure JVP, urine output. Urine output is one of the most sensitive markers of tissue perfusion. So put in a urethral catheter. That's assuming you don't have central venous pressure. This is what you do. I didn't say it. Oh, don't say it. I didn't say it. This is what you do if you don't have all the gadgets. Okay. Put in your urethral catheter. Measure the jugular venous pressure. Listen to the chest, and have an idea of the level of crepitations or what that person has. Then you can start your fluid slowly and increase. Watch the urine output. If the person is not making enough urine, you are not giving enough. If the person starts getting worsening crepitations, you are probably giving too much. If the JVP starts going higher from where you start, you are probably giving too much. Okay? If the JVP is not measurable or is getting lower, you are probably giving too little. Do you understand? So that's what you can use as a surrogate in the absence of available necessary things. But this is one of the cases that, please, you need a specialist, you need an ICU, you need to measure the central venous pressure real time so that you can titrate your fluid therapy. You should never give that person fluid by drop. You must use an infusion pump so that you can control the fluid that is going in. There is no place for counting drops. This is 15 per minute, 1 to this. Because one mistake, fiam, patient has gone. Somebody just moved this small. Somebody came and gave amoxiclav, Abi. Then the nurse just put it up. While they were doing, they just talk like this. No. Okay, so you must use an infusion pump to control that fluid rate throughout the period that person is on. So those are some things. So it's critical that you have those gadgets. Okay, I think I'll just take that last question. Final. Hope we're having a great time. Lots of things to learn. And there's so much we are learning today. And we are still going to do diabetes. We have basic life support today. So we are going to do lots of CPR here. And we'll do chest pain. We are running out of time. So breakfast is being served concurrently as we move on. And please take notes. Resist the temptation to develop phone disease. You know phone disease? Where your hand cannot stop. You must check Instagram, Facebook, WhatsApp. Please resist the temptation as much as possible. One of the reasons why we put a fee is not so that we can get money. You can tell that it costs much more. It's to make sure people are attentive. So you're already here. You can't be anywhere else. Take notes and grasp the mode. A lot of people that have come previous years, when they send in a report of an ECG, you think it's a cardiologist. When they send a referral letter and you see what they have started, that is how important the sessions are. So just pay attention and engage. Ask questions, and you will get it. There are some things we didn't cover. We thought we may be wrong. So ask the question and we'll bring it out. Please, sir.
Okay. Good everybody. I remain Dr. Solomon Umeke from Federal Medical Center, Kefi. My concern is follow-up of the last question and how it was addressed. I feel that question was addressed taking a standard practice. But I know that the person that asked the question has a concern. If he goes back from the village some of us came from, and such a case confronts us at the middle of the night, how do you go about it? So I was thinking that there are basic things we can do before we talk about the referral to a standard place. That's my concern, sir.
Okay, I thought I mentioned some basic things you can do. Did I? Okay, let me say it again. Let me just say it again. I said that the standard is to manage in an ICU and get specialist input. Standard. Okay? Now, I said that in the interim, you don't have it. You don't have a specialist in the next 20 kilometers, 30 kilometers. Set up your IV line. Close monitoring of the patient. Every 15 minutes, blood pressure and pulse. Listen to the chest. Document all of that. Pass a urethral catheter. I think I said that. Monitor the urine output. You need to monitor that urine output hourly. You want to monitor it hourly. You want to get 30 to 50 mils per hour minimum of urine output. Now you start your fluids and start slow. You typically want to start with something like 500, 6 hourly. You don't want to do rush. But you need to use the patient's response in the absence of a CVP to monitor that fluid therapy. One of the ways is to check that urine output, which I said is the most sensitive, what did I say? Marker for tissue perfusion. That's one of the most sensitive markers for tissue perfusion. You've taken out the first urine. After you're giving fluid in the first hour, you did not see urine again. Your tissue is not getting enough perfusion. You need to now increase your fluid rate, your rate of fluid. Also check your JVP. In that patient with heart failure, the JVP may have come down, and use that as a surrogate for the central venous pressure. If the JVP is coming down every hour you use that to measure how much fluid you are giving. Number 3, I said check the chest. If you start getting more crepitations, you are probably giving too much fluid. Okay? So, but you must correct the fluid. Start with your fluid as you will have done, but not as fast as you will have done. Give it slowly and check these markers. This is a case you must measure, you must monitor hourly. Hourly. Now you must get input, even if you cannot get a specialist. Wherever you are in this country, there's GSM. Okay? There's GSM. You must get input from a specialist. Get your ECG. Get all those things. You must remember that hyperglycemic emergency you're talking about may be because the patient has suffered a heart attack. The patient suffers a heart attack, the high blood sugar you are seeing is a secondary response to a heart attack. So you still have to check your ECG every time. So you must go through these things, just exactly what we have done, step by step. Check the blood sugar, check the ECG, check the urine output, check the chest, follow it step by step. This is what you will use to monitor in the interim, pending when you get all of this. Now, you may never get it. Even if we use all of this is how we trained. We did not train with ICU. That's the truth. Now, so we take DUAM. So it works still. You sit down with this step by step, and you know what you are doing, and you have specialist input. This is what I have. This is the ECG. This is this thing you can successfully manage the patient. You also use the blood pressure. You have somebody in front of you now. You have the previous history. Blood pressure was always 130/80 in heart failure. Now the blood pressure is 80/50. You're already low. You start correcting your fluid a little bit more aggressively. You use that blood pressure to check while you are checking the other parameters, so that you don't kill the person with hypovolemic shock and say, no, the person is heart failure, and you did not correct hypovolemic shock. Dr. Officer, you want to add anything? Okay. I hope that is clear. You need any extra again? Okay, thank you. All right. Over to you. Thank you very much.
We do better. Is it the small chops? We can do better now. All right, that was a wonderful one. And guess what? We still have more in store for you. Coming up, we have special presentations that will be taken by some of our partners. To present first, we have Vastovas Pharmaceuticals. Please kindly make them welcome.
Hello, good day, everyone. I'm very happy to be in your midst. I hope you've all been enjoying the symposium, because I have, and I've learned a lot. So we've been talking about some disease states and the medication of choice to use. But then just imagine you have a hypertensive emergency, and then you're trying to give labetalol, 30 milligram over 24 hours, but then it's adulterated. I think that's a big disaster, yeah? Okay, so I am pharmacist Chiso Miriam Oyekwelu, and I represent Vastovas Temot Limited. Today, we'll be talking about professionalism in the procurement of drugs and allied products in contemporary medical practice. Firstly, let's look at what's the key facts about drug. Drugs are any substance which has physiologic effect when ingested or otherwise taken into the body. So that means it has the ability to change the state of health when ingested into the body. Then drugs are potential poisons. The intention and dosage makes the difference. So that means a drug can kill somebody, and then it can also give life to somebody. And in that fact, you would agree with me that it is a very vital part of human life. And in that sense, non-professionals should not be allowed to handle drugs no matter what. So the study of drugs is composed of various disciplines. Across the globe, you have nothing less than 4 years to study drugs for you to be called a drug expert. That's like a pharmacist. So, next slide. Let's look at issues associated with purchase of medication. Number one, we have possibility of fake and adulterated products. In Nigeria, studies have it that over 60% of drugs used in Nigeria are imported. And in that, you know that storage and transportation compromises are very, very much possible. You can't determine that this particular item was moved safely from Lagos to Nigeria in the right storage temperature. So there are lots of compromises. Then in the East where I come from, they do a lot of apprenticeship. So even in the drug business. So most people or some people see it as a buying and selling business. I buy for 10 naira, I sell for 20 naira. So every other thing about drugs, they really do not know. They just see it as a commodity. So in that term, you can have fake drugs in circulation because they are really not informed. Then the second issue we have with drug procurement is poor services, insufficient capacity, reliability issues. In insufficient capacity, you have, let's say, a particular hospital, you need 100 medications, and then you send it out to a wholesale outlet, and then they're able to give you just 50. So you have to go around, check this other place. So it's a problem in drug procurement. And then you might have a patient that really needs a particular medication, but then you're busy moving from place to get that. Then you have poor services, reliability issues. In cases of any issue at all, like let's assume there's you got a drug in your premise, in a pharmacy or in a hospital, and then there's cases with the NAFDAC. Wherever you bought the drug, it's expected that the person should stand and vouch for you that, yes, this medication was gotten from us. In fact, take up the case because they are certified. They know where they get their supplies from. Now, let us talk about who we are and what we do. Before, when I started, I said I represent Vastovas Temot Limited. So now, who is Vastovas Temot Limited and what do we do? Vastovas Temot Limited is a branch of Vastovas Group. This particular branch does with wholesale and distribution of drugs and allied products. When I say allied products, I mean your hospital consumables, your equipment like your glucometer, and a lot of it. Then we are licensed wholesalers, distributors of drugs and allied products, certified member of Pharmaceutical Wholesalers and Distributors Association of Nigeria. We have high network of credible business affiliates across the globe. So then we intermediate between your facility and numerous credible manufacturers across the globe. We run NAFDAC recommended functional SOP for drug distribution and all. So in Vastovas Temot Limited, we appreciate professionalism. We care about human life, and that is why we have different departments that handle different processes. So ranging from your procurement down to sales department, you have professionals in charge of this. When I say professionals, I mean there are pharmacists in charge of these departments. From your procurement, we make sure we get from the right source, certified suppliers, direct from the manufacturers, and then down to sales. That even when you come to the shop floor to shop for your drugs, you have pharmacists that are there to give you any form of assistance you might need. Then our work protocol, we get from certified suppliers, I've already said that. We have logistics in place for proper movement of those drug items. And then we do quality control checks as well. We don't just get drugs and then that's it. Even in as much as we are getting from the right source, when it comes to us, we also verify that this is supposed to be like this, and this is this and that. We also check all of those. Then we run NAFDAC special drug scheme. This offers us importation permit for scarce drugs. There are some drugs that are really very scarce, but then when you come to us about it, we have this permit to import scarce medication. So you don't need to run around from place to place. Just let us know about it and we'll help you do that. And then there is online ordering. This gives you ease. You don't need to come to the shop floor. You don't need to come to our office. You just have to place a call or maybe send us an email. We give you what you need. Okay, there's a home for ethical drugs, just like I explained. There are some medications that are not readily available. So you need a company that has high connection across the globe that will be able to get it for you when needed at the right time. Okay, so now what do you stand to gain in partnering with us? I've talked a lot about Vastova. So now, what do you stand to gain? So because I believe everybody here is a healthcare professional, a medical person. So you can't afford to make preventable mistakes. There are mistakes that are preventable. You get a cold chain, let's say MMR vaccine, and then from where it was bought, it was removed from the ice pack and then moved to the facility, and then there's a problem. Or maybe insulin, for example. So there are preventable mistakes that you don't want to make. So we help you because we value human life. We help you to prevent those kind of mistakes. The quality of the products you get from us is assured. We don't just get medications from anywhere. We have the right source. So if any issue comes up, Vastova Stemots Limited will take it up and defend you. Then we are veritable partner in progress. Our service goes beyond selling. We don't just sell medications. Yes, we can give it, sell the medication to you, but then we follow up. Like, is there any issue? Would you want to do it? We have a very good return policy. So there are a lot of things that have to be in place in medication purchase. It's not just about selling. Then we offer pre, during, and after sale services. Before we order for you, we get the vital information we need. Even during the transaction with us, we still follow up. We make sure that your order is serviced, if not 100%, but at least 90%. We are your friend for excellent business relationship. We have a very good relationship with most of our partners, and I will say that is part of the reason why we are here in Limi Symposium, because we have great relationship with them. We are professionals, and then we offer a large scale of information. When you have any information at all you need, maybe the medication you got was not exactly what you needed, you can always call on us, and then there's a pharmacist to explain, yes, this is the same as this you ordered for, and exactly things like that. We bridge the gap created by drug availability issues. I've also said that even if we don't give you 100%, we try as much as we can to give you 90%. We relate to you, say, these things are not in stock, but then if you give us 24 hours, we'll make it available. So it depends on the customer to say, okay, we will go with this or we will not. So this is a pictorial representation of what Vastova Stemots Limited looks like. This is the shop floor. So we have a wide variety of drugs and allied products. As you can see, this is directly from the office. It's not an internet picture. All-inclusive stocking. You have wide variety, scarce medication, anti-cancers, anti-hypertensive, what have you. Then our cold chain, we have a 24-hour power supply system. We are all in Nigeria. We know what it takes to get this in place. But I can assure you that in Vastova, it is very much in place. And apart from being in place, on a daily basis, there are professionals, there are personnel trained to always do temperature marking to make sure that these refrigerators are in the right temperature at each and every point in time. So we have a wide range of hospital consumables, from your gloves down to your syringes, and our MOU engagement. This means a memorandum of understanding. So you can get into an MOU with the company. We have specified credit limits. That's the amount you think your hospital or your pharmacy can consume in a month. Then specified duration of payment. So with this, it gives you rest of mind. The only thing you need to do is to call on us or maybe send us an email of the drugs you need. It runs on autopilot. We deliver without stressing you. When are you paying? What is the form of payment? Because all of those things have been documented already. So even if you're outside the country, just be rest assured that your pharmacy, your hospital is in good hands and will be running. So this is a publication that was done in 2021 where a case of ischemic heart failure was, we intervened. There was a particular medication that was very scarce and not readily available. But in this case, they called on Vastovas and we were able to supply the medication and the individual was saved. So they made a publication of that in 2021. Then we have our clients. We supply medications all over Abuja and even beyond, not just in Abuja. So some of our clients, the hospital, the Limi Hospital, Nizamia, Cedar Crest, Zenith, a lot of it. Corporate clinics like the Defense Intelligence Agency Clinic, ECOWAS Clinic, pharmaceutical wholesalers, retail pharmacies, all these are part of our clients that we supply and do business with. Thank you very much for listening and welcome on board. I believe with everything I have said, with all I have explained, you see that Vastovas Thermos Limited is an organization to do business with. So welcome on board. For further inquiries, you can either call these numbers or we are also there for now. So you can always visit us and then make more inquiries. Thank you very much.
Thank you, Vastovas. Quick one. Actually, all what she said is not a sales pitch. I've actually visited Vastovas on many occasions, and I did get my money's worth. Please make them welcome once again. Okay, up next, we have Codex. Codex, are you ready with your presentation? Okay, please make him welcome. Are we tired? Okay, let's stand up. Let's all stand up. Let's all stand up. Please indulge me. Let's all stand up. And let's clap. But wait, the clap is going to be in a particular way. I'm going to show us how we're going to clap. So when I do this, you clap. I do this, you clap like that. So clap, 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 clap. All right, excellent. We can sit down. Codex, you have the floor.
Thank you. So I'll say good afternoon to all, and it's a pleasure to be in our midst again. Pharmacist Jackim is my name, and I'm really pleased to have this moment of engagement here. Basically, just to discuss the 360 degrees of patient care, the Codex intervention. And what we will look at is what we do in Codex. Our vision is to be a leader in African, and a leader in pharmaceutical health tech business in Africa. And to achieve that, we have a mission. And the mission is to improve the healthcare of the nation through access of quality, innovative, technology-enabled healthcare solutions and preventing early diagnosis and treatment solutions. We, as a company, exist in up to 8 different countries, but we are an indigenous company, a Nigerian-born company, but we are presently operating in these different countries that we see: Liberia, Ghana, Sierra Leone, the UAE, and the UK. We have business partners that we operate with, and reputable amongst them, I must mention, is SD Biosensor, who is an in vitro, a world leader in in vitro diagnostics. Basically, what we do as we go on, we'll see, is we play in areas of diagnosis, we play in areas of prevention, and in areas of treatment. I stand to say that we're about the only pharma company, that indigenous pharma company, that plays in these 3 areas of healthcare management. To address these concerns, we've understood some gaps in right treatment. One of the gaps we can identify is knowledge gap of new trends in healthcare management and delivery. Also, we've understood that there's accuracy in diagnosis for appropriate referral. It's a gap in the health system. Turnaround time of laboratory results is also a very big gap where patients have to be told to come back after 24 hours, after 48 hours, as the case may be. Loss of revenue due to outward referrals because a facility cannot carry out a required diagnosis. Out of stock of right medications and reagents. Lack of funding to equip facilities to be able to enable them deliver the right solutions. And also the skill gap, which is quite important because of the sophistication of technologies and achieving the right solutions. Now, our solutions in this space, we start with our preventive medicines, what we call the wellness, Codex Wellness. For the Codex Wellness, we have one important multivitamin, which we call the Winwell multivitamin. The Winwell multivitamin is unique because of few contents, compositions of biotin, chromium, and lithium. These are important ingredients in our multivitamins that has extensive benefits. Also, we have a combination of vitamin C and D as an effervescent tablet. It coming in this form gives us the milligrams of vitamin C and 400 IU of vitamin D. And being that it's effervescent tablets, it has a very palatable taste and it can be given as a drink daily. We also have our Cell C, which is a composition of selenium. And we know the benefits of selenium in terms of improvement of the immune system. A very vital medication for even HIV case patients. For the treatment portfolio, we have a combination of medications, which are basically generic medicines, running from atorvastatin tablets, 20 and 10 milligrams. We also have diuretic furosemide, which is our brand of diuretic, our brand of amlodipine, 5 and 10 milligrams, and then our brand of metformin, which we brand as Glucodix, the immediate release, and also the extended release coming in 500 and 1 gram doses. And lastly, we also have a combination of metformin and pioglitazone. Now, coming to the area of our focus, which is in diagnosis, we have a range of point-of-care devices that we use in our analysis, that will aid your analysis and also ease the treatment choices. The first we have is our Clover A1C. For physicians who are aware of our Clover A1C, can always say that this is one of the most durable Clover A1C or HbA1c device that has been existing in Nigeria since 2010. Our Clover A1C has been in the country, and most endocrinologists have given a very good remark about its analysis. It gives us a HbA1c result within 5 minutes. I think it's as exciting as that within 5 minutes, a patient before the doctor, before the next patient, he's able to tell the HbA1c status of his patient. And it's very easy to use. So even it doesn't need a specialized skill set to be able to handle this device. Next we have is our Lipid Pro Analyzer. Our Lipid Pro Analyzer is also a very portable device that gives us the benefit of analyzing high-density lipids, low-density lipids, total cholesterol, and triglycerides, all in a single test within 2 minutes. This device has shown very good features for us because you're able to run a lipid profile for a patient within 2 minutes, of course, in the morning fasting lipid profile. One of the very unique parts about this device is the temperature, which I should say that operation temperature should be within 18 to 30 degrees temperature. Higher temperatures often affect the result, so it's important we mention about this, about the device. Next also we have is our blood glucose meter, which is about the second most selling blood glucose meter in Nigeria. Our fine test meter. What's unique about our fine test meter? I can say that it's very easy to use because you don't need so much blood, as low as 4 microliter of blood, because the blood is by capillary action. So there are no cases of loss of strips because adequate blood is not obtained on the strip. It comes about the only meter that comes with extra 25 strips in the pack. So it's that's very accommodating. Also, you are able to get your results either in millimoles per liter or in milligrams per DL. as the case based on how you want it or how the patient wants it. It's auto-coding, meaning you don't, once you change the strips is finished and you get a new pack of strips, it automatically detects the code. So you don't need an extra barcode to insert in the machine or the device. And the result comes out in 9 seconds. And one other interesting part about it, it carries an ejector button where it's able to reduce contamination of blood of handling. So once you're done testing, with an ejector button, you throw down the strip of the device. The next we have is our hemoglobinometer. The benefit of VeriQ is it's able to give us PCR and hemoglobin in 5 seconds. I think this is one very wonderful device that runs in pediatric clinics in accident and emergency cases. It's battery run, the AAA battery, 2 batteries, and so it's very convenient. There are no cases of, no matter how urgent the PCV is that is required, our VeriQ meter can deliver that report for us. Lastly, to talk about, very importantly, our fluoroimmunoanalyzer, which is one of the new trends for diagnosis. The fluorescent immunoanalyzer, we have 2 types, the F400 and the F200. And the beauty of these devices is that it's able to give us analysis of many different parameters. One of the uniqueness of this machine was seen during the COVID era, where it was able to use to help run PCR, miniature of PCR testings for COVID. And further to that, we've seen it in benefits of cardiology, oncology, and endocrinology. And just to highlight the biomarkers, for cardiac biomarkers that it does, we see the benefit of NT-proBNP, D-dimer, highly sensitive CRP. And we know the advantages of these markers. For NT-proBNP, we've had recently on heart failure. NT-proBNP helps in the diagnosis and monitoring of heart failure management. D-dimer, we also see it as a case of reducing pulmonary embolism, yes, and highly sensitive CRP. So also troponin I and troponin CKMB. These are about the parameters that this device can analyze. But one unique feature I will mention about the F200 and F2400 is this is a multiplex device that can run multiple tests per time, as much as 24 tests per time, and the maximum turnaround time is 15 minutes. So within 15 minutes, you can run 24 samples per time, and in an hour, as much as 74 patient samples. So for high flow patient hospitals, you can have good turnaround times with this, as compared to the F200 that can only run 1 test per time. And that's about it. For more of what we do, just to say that we have other areas of diagnosis, radio diagnostic devices, and also our range of rapid diagnostic test kits. Thank you very much. Just to say we are at the back here for more inquiries relating to costing, relating to how we can do business, how we can partner. We are just at the back and we'll respond to you. Thank you.
Thank you, Codex. I would advise us to take him up on his offer, even if it's just for the freebies, the pens and the key rings and what have you. Okay, so for those just joining us, you're welcome to Abuja Cardiac Symposium 2020. When we take our pictures, remember to hashtag ACS 2022, hashtag CardioCare on your social media. That's your Instagram, Twitter, Facebook, whatever. Moving on to the next segment, we have a presentation on evaluation of chest pain, and this will be taken by Dr. Iseko and Dr. Anya. Please kindly make them welcome.
All right, good afternoon. We are a little behind time. I want us to stand up for 1 minute, just not 1 minute, 10 seconds, stand up. Let us practice what we preach. Stand up, stretch. Now I want you to stand on your toes, up and down, up and down, so that we don't have DVT here. Up and down. Now I want you to take a very deep breath in In, hold it, and out. Now the next one, you're going to take a deep breath in. You're going to breathe out Nigeria's troubles. So breathe it in well. Now breathe out all Nigeria's troubles. All right, now you can have your seats. Thank you. They say sitting is the new smoking. That sitting for long hours has the same cardiovascular risk as smoking. So it's quite important, that we stand up from time to time. So it's quite important. So we'll talk about chest pain. Recently, I don't know, over WhatsApp and in lots of the WhatsApp groups that I'm in, there was a story shared by a former minister of this country. I don't know if people saw that story, of a patient that had chest pain, went to an emergency room in this hospital, in this country, in Abuja actually, and then was asked to go home, and later was brought in dead. Who remembers that story on WhatsApp? A lot of us. So when some of us saw that one, we were like, whoa. So this is one of the things that we've taught chest pain before, but I'm not sure we've taught it quite like this. If you look at your jotter, you will see a chest pain algorithm. A chest pain algorithm. So please go through it. If somebody can help me with the page number. A chest pain algorithm that tells you, well, at least for our local setup, what are the things you can do if somebody comes with a chest pain. So somebody comes with a chest pain first. The first thing you should do there, if anybody can find the page number so that other people can, page 14, page 14. You see a chest pain algorithm. There are other algorithms on how to manage cholesterol. I don't know if that is going to talk about cholesterol a bit. There are algorithms on management of blood sugar, when a pacemaker is needed. There are algorithms on what to do in certain situations. If patient has tachycardia without a pulse, with a pulse, what you should do, cardiac arrest, step by step. So keep that jotter handy. You're going to use it a lot. And then there's an algorithm of how to read an ECG. You're going to use that jotter a lot. It's not just a jotter, it's a life pack. Okay. In the next 2 years, you will still need to reference it. Okay, so if you look at that, that particular one, you can see what will happen when somebody has I'm just waiting for my slides to be ready. You can see what will happen when somebody has chest pain. Okay? So the first thing you can see there, if I'm not mistaken, should be an ECG. Is that correct? Is that correct? ECG. Yeah, so take a brief history and take an ECG. Please, an ECG must be done within 5 to 10 minutes. That is the global standard. Anybody coming with chest pain to your hospital, because you have come to ACS, you are an ACS alumni, you must have, so write to your an ACS alumni, you need to have an ECG. Be careful, make sure you have another job. But you need to have an ECG. Now, ECG should not be one that is locked up in the matron's office. You get, they will now bring it out when it's time for accreditation. No. It's not the one that there's an ECG room far away. The patient comes at 2 a.m., the ECG technician has closed, is locked. ECGs must be there within reach. And you should be able to do an ECG within what? How much? 5 to 10 minutes. You should have it interpreted within 10 minutes. Now, I'm going to equip you to be able to interpret it, so don't worry, just be relaxed. So far, you can see, you can read an ECG, I assure you. And if you cannot read an ECG, we'll make a bet on something else. Okay? So within 5 to 10 minutes, you have an ECG read. What do you do next? It now depends. You will see different flow charts. So one of the next things you need to have in your hospital is the ability to check cardiac enzymes as much as possible. Codex has told us a lot of things for checking cardiac enzymes. One of their machines, they say, can get us the troponin within 15 minutes. Now, if you don't have that, you should be able to have a center that you know that you can take a sample and send. And as we go through the chest pain algorithms and chest pain management, you will see how important troponin is in the diagnosis of chest pain. In the United States, up to 11.8%, as the last time I checked, of people with chest pain are wrongly discharged from the emergency room. So I know a lot of people, thank you. A lot of people were quick to say, these Nigerian hospitals. No. In the United States, up to 10%, 1 in 10, is wrongly sent home with an MI. and actually comes back either dead or has to be rushed back with the ambulance. So we're not doing badly. Don't say everything bad about Nigeria. Okay? So what we just want to do now is to talk about chest pain and how we can get better at managing chest pain. The lecture brought by Cardiovascular Hospital. Our vision in the Limi Hospital Group is to empower Africa through a healthcare ecosystem for training, research, and service delivery. That's why we are doing these trainings. Okay, we have been doing this for the past 6 years. Initially, it was a small room. We moved to the bigger room, then the much bigger room. People insisted that it must be done over 2 days. Then we did it over 2 days. During COVID, we did it online, yes, throughout, and it was very well attended. And then we had a physical BLS session, and we've continued. Last year, we were here, and we said that this role was much better than where we started. For those that know where we started, know that we have tried. All right, so cardio care. This is cardio care in the center there. There's also Limi Hospital, which is the main hospital, and the Limi Children's Hospital. Our pediatric cardiologists usually used to join us. Next year, by God's grace, we hope we can revive the annual Abuja Pediatric Symposium. And you will see our pediatricians in action at that time. And I hope you will all be here. All right, and that's cardio care. So the goal is to understand, detect, treat, and prevent complications. Let us understand. Let us be able to detect the condition promptly. Let us be able to treat. Let us be able to prevent. When a patient comes to your clinic or your hospital with chest pain, be 100% sure that at least you have done what you are supposed to do. That should be very good, because you never know. It could be your brother, your mother, it could be anybody. They could call you from home now, from village. My papa is having chest pain. Okay? So that you'll not be among people that say, go and drink Panadol first. Okay. So this is case one. Case one. 24-year-old man, Mr. AJ, insidious, non-radiating left-sided chest pain that is waxing and waning. Is aggravated by body positions, by coughing, no significant relieving factors, query relieved by paracetamol. All right, it has lasted for hours since onset, is moderate in severity. They had similar pain about 2 months ago after an upper respiratory tract infection. He's not a known hypertensive or diabetic, and no known elevation of lipids. He drinks socially. I don't know what that means, but he drinks socially. And occasionally smokes Igbo. This is a real-life case. It's a real-life case. It's not a hypothetical case. When he came into cardio care, he was rushed into cardio care ER with pulse of 106. Blood pressure was 146/76. Heart sounds were normal. Respiratory rate was 20. SpO2 was 98% in room air. So question one, what kind of chest pain is this? Yes, what kind of chest pain is this? We are going to our polls, cardiocare.ng/polls. If you're already there, cardiocare.ng/polls. What kind of chest pain is this? This man that had this young man, 24-year-old, left-sided, non-radiating, it has been there for some hours, moderate severity, no significant relieving factors, aggravated by body positions and coughing. What type of chest pain is this? Can we? No. What's happening? What's happening, Mr. Eno? It's showing the previous one. It's showing the previous. This is from the previous something. End it. Go back to the previous one and make sure it's closed. It's not there. Okay. Give me back my slides. Okay, fine. Good. So let's vote. What type of chest pain is this? This young man. Thank you, Mr. Eno. The number of I don't know is cut off. Can you hear me check what it is? Okay, so we have atypical chest pain, non-cardiac chest pain, typical chest pain, and I don't know, 9%. Please limit I don't know. Try. Try, even if you fail, try. We are not voting Peter Obi, Atiku, or somebody. Just vote. Just vote. All right. So, what's happening? Sorry. We keep on trying this technology. Okay, so we typically evaluate chest pain by three criteria. Number one, is the chest pain left-sided? Number two, is it provoked by exertion? Number three, is it relieved? You see that also in your book. These three criteria. We say it is typical when all three are there. In this case, was it all three? No, definitely not. We say it is atypical when there are two. That is, there was presence of left-sided chest pain, or this is a WHO chest pain algorithm. And then, if there are at least two of them, were they up to two in this case? Hello? Remember the young man? It was relieved. There were no relieving factors, query paracetamol, and it was aggravated by turning and by coughing. So, the only thing that was there was one, that there was chest pain. It was not provoked by exertion, and it was not relieved by rest or nitroglycerin. Do you understand? 1/3 is what? Non-cardiac chest pain. So you can see that our answer was not quite correct. Non-cardiac chest pain. Mr. Eno, there's something wrong somewhere. Keep on bringing up that one. So when you are now taking the history from that man, some things that you must be there. Precordial, retrosternal. Find out. Where is it? The next thing, find out what are the aggravating factors. If this patient we talked about that came to this hospital, they should have done this one. They should have used that algorithm. They would have ended up in the correct, hopefully. Okay? Find out what are the relieving factors. How long was the pain? Okay? And find out, are there any associated factors? Diaphoresis, that is excessive sweating, dizziness. Are there any other cardiovascular risk factors? You must ask. Please and please ask. Also ask if they have been smoking anything. We had a 22-year-old that came into cardiac care emergency room, rushed everything, then we looked at this boy. First of all, we saw from his hairstyle and the kind of guys, his profiling, Abi. We saw the kind of guys around him. Then his way his pupils were and the way he was just, initially, some people started, what I said, no. This is not. We just gave diazepam and everything started coming back down. Fortunately, he came back 2 days ago, almost 2 days later, with almost the same thing. So the guy did not learn. Okay, so check for, especially in Abuja and Metropolitan, and find out if they are not taking something. Now, these characteristics are less likely to be cardiac. I'm not saying it is not cardiac, but it's less likely. When it is very sharp and pinpoint, like some of us now are already feeling chest pain, we're not sure whether we have chest pain or not. That kind of one is typically sharp, pinpoint, just at the left. That one is typically, it's not like it's not, but it's less likely. When it's directly under the breast, it's also less likely. When it lasts for a few seconds, it just comes, fiam, and goes, it's less likely. When it's lasting for days and the person is still going to work, eating, doing everything normal, it's less likely. Do you understand? So it's more likely a person is having a heart attack and they are unable to do a lot of things. They are getting more diaphoretic, they are more breathless. The person comes, I've been having chest pain for 2 weeks. And, he's gisting, he's on the phone, he has done everything, he slept. He said even when jogging this morning. It's not that it cannot be, but it's less likely. If there's focal tenderness, you touch and you can feel pain, it's also less likely. If it's posture related, like this case, it's less likely. If there are no cardiovascular risk factors, it's not hypertensive, not diabetic, you've checked, the cholesterol is fine, it's less likely. So you now check if there are any of these things. Whenever you have 2 or more of these pretest risk factors, then we say that there is a high pretest probability. This patient has had a stroke before, high pretest probability. Family history of sudden cardiac death before the age of 40, or cardiac disease before the age of 40, high pretest. If they have only diabetes, high pretest. So diabetes is big. Okay? So if they have one or more of these, if they have only one, then we can say intermediate. If they have no risk factor, then they are low risk or no risk. So that is what we're going to use in this our chest pain algorithm. So you can open your chest pain algorithm on your manual, and look at it. This young man came in, and if you are not sure and you don't have an ECG, please refer. Heart attack, myocardial infarction is not something to play around. Please don't start doing MP and full blood counts. Please. Because sometimes you get the referral letter and you see MP results. That means you waited for the MP result to come out. Please. Chest pain. 12 ECGs within 10 minutes if there's ongoing chest pain. So this is the kind of thing you should keep with the nurses that are taking vital signs in your hospitals. So all of you that are going here as ambassadors. When Nigeria is better, we are all better. We are not going anywhere. We stay here. We stay here. We don't go anywhere. So Nigeria must be better. That person that is checking vital signs should also ask if there is pain. Pain scale is a vital sign. Please don't forget, asking for pain is a vital sign. If they say they have chest pain, they should not go and join the queue. I'm waiting to see doctor, 20 people in front, and be fighting who is next. They should go straight and have an easy. So in this case now, this case we just discussed, where does this patient fall? Is it high, intermediate, or no risk factor? Yes, this young man, the 24-year-old. Anybody? Yes? Try now, try. The highest that will laugh. Try. The young man, you remember the young man? This young man, look at the case again. If you cannot remember, look at the case. Is this a high pretest probability, medium or moderate, or low or no risk pretest probability? Which one is it? Hello? No, there's nothing there. It's not hypertensive, not diabetic, no risk factor. So we didn't get any risk factor in this case. So automatically on our algorithm, he's going under this place of no risk. What do you do next after that? Check that your ECG. If the ECG is normal, follow this pathway. Exclude other non-cardiac causes. If the pain you are still unsure, please do troponin. Okay? Negative troponin, continue excluding other causes. So you have a normal ECG and you have negative troponin. If he has an abnormal ECG, despite having no risk, we have had patients come with myocardial infarction and, with no risk factor. Not just one vessel, 2 vessels blocked. So it doesn't exclude it. I want you to just know that. There's one man that came from NSCDC, slender. That guy is very slender, fit. I had to look at it again and again and again. So don't write it off and say the person is not fat and is not rich. It's not for rich fat people anymore. Okay? So abnormal ECG, please go straight to do troponins. After the troponin, then positive troponin, you must begin to treat like a myocardial infarction. Okay, I think you can see that. If it's other risk, the same way is the way you follow it. Please, you have this thing in your notebook, so you can refer to it again and again and again. Okay? So, how do we now look at the ECG? What do we look at the ECG in terms of what to do? This is what the ECG is. And on the ECG, we are typically looking at the ST segment. And we can see the ST segment here. Can we see it very well? That's the ST segment. We typically look just one small box after this junction. So at this ST junction, just one small box. We use that to decide. When it is elevated, we say it's ST elevation. When it's depressed, we say ST depression. And sometimes it is okay, but there's a T wave inversion. All these are abnormalities that you must take note of. Hello? Is it hard? It's up and down. Okay? It's like dollar, up and down. Abi? Fine. Now, for us to be able to say that there is something, we must also make sure that it is not only in one lead. It must be in 2 or more contiguous leads. And you see the list there also in your workbook. The 2 leads must be from the same area. So, 2 people that are looking in this direction must all agree that what they are seeing is high. So, 1 AVL, V5, V6, 2, 3 AVF, V1, V2, V3, V4. If any 2 of them also confirm this, that is not normal. Don't send the patient home. Don't send the patient to clinic. Say, come back. We book you for 2 weeks' time. Okay, where people that are doing ECG can read the ECG, they will trap the person there. Sometimes people were going for normal surgery, just hernia surgery. They came to do ECG pre, and we caught them there. And then took them straight to the ICU from them. Please, you need a review immediately. You need a specialist input immediately. Okay? And then we'll go forward. So the case again. This is the case. We've gone through it. The next question is the history and clinical exam adequate? So let's go back to our polling site. Can we go back to our polling site? Don't worry, we don't know who picked what. So pick anything. And don't be afraid. We will not call you that. Why did you pick this one? Something wrong here. Wait, you're saying okay. It's now it was saying not connected before. Okay, let's have a slide. Still showing the wrong thing. Okay. Is the history and exam adequate? 73% said no. What is missing? Can somebody endeavor to tell us what's missing from the history and exam? 27% said the history and exam is adequate. Among people that said no, can you be bold enough? Anybody bold enough to tell us who they voted for? Don't worry, we'll still give you contracts. It doesn't matter who you voted for. Yes? Anybody? What is missing? Everyone's afraid though. 77 people voted. So, shall I go ahead?
Okay, so now that we've determined it's non-cardiac pain, we need to go further into the history taking, like, you know, there's fever and other things, associated symptoms. And also we need to do further examination, listening to the chest and all of it.
Good.
Attain the diagnosis.
Thank you very much. So checking for chest wall tenderness, fever, malaise, are there other things that are there any persistence? Is this the first time he has had it? Has he been having it before? All that will make for a more complete examination finding. Thank you very much. So, what's happening? So this was his ECG. We'll get the technology finally. All right, so this was the patient's ECG. For those that were here last year, is there any abnormality on this ECG? Or for those that are here now, any abnormality on the ECG? So let's start like we normally do. We check the heart rate. What is the heart rate? 1, 2, 3, 4. 300 divided by 4, that's 75. That is okay. That is fine. We check the P wave. The P waves are upright here, and they appear before every QRS. That is fine. The PR interval is prolonged, so there's a first degree AV block. Right? We can see that. See where the P wave started from. This is where the QRS started from. It's more than one. See where the P wave started from? On this line. And then it's more than one big box. The P wave started on this line, and it's more than one big box. So there's a first degree AV block. Then we look at the QRS complex. It's narrow. Very good. Then we look at the T wave. Can we see T wave inversions there? Hello? Can we see the T wave here? It's upside down. The T wave is upside down here. It's upside down here. Don't worry, we'll soon do ECG. You will read ECG like anything. The thing is very easy. It's like reading ABC. We can see T wave inversion in one hand. So this ECG is not completely normal. Okay, it's not completely normal. These were the results of this boy's investigation. ESR was 30. White blood cell count was this. Cholesterol was okay. Urea creatinine was this. Fasting blood sugar was that. Troponin was normal. Troponin was normal. ECG was not so bad. And stress ECG was negative. What do you think the final diagnosis is now? Yes? What do you think the final diagnosis is? Go to your algorithm. Follow your algorithm. Follow your algorithm. In the algorithm, he's on pathway 1. The ECG was relatively normal. Or he was on pathway 2. The ECG had abnormality, right? Hello? ECG had abnormality, T-wave inversion. So we did troponin. Troponin was negative. We did stress ECG. It was negative. So negative troponin means what? Exclude other causes. Can you see it's very simple to use? This patient now, if you allow the patient home, you can feel at least that Americans too will have missed it. All right, so what do we think the final diagnosis is? This is my slide though. What do we think the final diagnosis is? What's the final diagnosis? Yes, let's guess. Is it an MI? No. ECG was fine. Troponin was negative. Right? So not a myocardial infarction. Look at your algorithm. Follow your algorithm. Okay. It's unlikely to pulmonary embolism. And in this case, and there was no fever. The chest examination was fine. So we are looking more like a costochondritis. Let me tell you that most cases that come to the clinic, cold, young people without any risk factor, are most likely having musculoskeletal pain. And the chest pain was also less likely. So, we'll move on. I want to explain this again. Do we all understand why it is not a heart attack? Do you understand why it's not a heart attack? Negative ECG is negative ECG, negative enzymes could either be normal or could be an unstable angina. Negative ECG, negative enzymes. Think of it that this could be normal or it could be an unstable angina. Negative ECG, hello? Negative ECG, like this patient, and negative enzymes could be normal. Negative enzymes, in this case, and a positive ECG. This ECG is not quite positive because the patient did not quite have all the parameters. And so in that case, we say we are dealing with a costochondritis. Is there any question, please, so far? We are getting a little bit heavy. Is it getting a little bit complex? Getting a little bit complex? Not too complex. It's easy for you now. Not Nena. It's easy, Abby. Yes. So the chest pain nugget 1. Everybody must have an ECG within 5 to 10 minutes of arrival to the emergency room. Everybody. Please don't forget this. We've had a case. The woman has been coming over and over again. One chest pain here, one chest pain. We have done ECG, stress. It has been negative for 2 years. 1.5 years ago, she came again with chest pain. If not for our algorithm that everybody must have ECG, her ST elevation was now there. Finally, what she had prayed for. So it was there, inferior leads. I had to check again. We repeated it again. We checked all the ECGs we have been doing before. So don't say that this person has been crying wolf before, so they cannot have it again. Do we understand that? Every time somebody comes with chest pain, they must have an ECG. And it is a medical legal thing. That is what will save your license. And now you have this extra certificate that will stand against you, that somebody told you. Check the ECG. And if you can, check the cardiac enzymes. So please make sure you do that. I'm going to have to hurry up. In this case, we have this 56-year-old with worsening sharp chest pain, 2 days duration, aggravated by coughing and lying flat at night, relieved by sitting up, radiating to the left arm and back. There was nausea, there was fever, there was tachypnea. He's a known hypertensive. He's had stroke 3 years ago. This is a real-life case. And then he has residual hemiplegia, does not smoke or take alcohol. He was rushed to cardio care, emergency room with an ambulance. Pulse was 112. Blood pressure was 146/76. Respiratory rate was high. SpO2 was 88%. Chest exam was normal. What kind of chest pain is this? Yes? What kind of chest pain is this? Remember, just 3 criteria. You can use your book. The expo is inside your notebook. What kind of chest pain is this? Can we try? Close the pole that she did that time. It may still be open. What kind of chest pain is this? It's still showing that one. What kind of chest pain is this case? We don't have time, oh. We don't have time. What kind of chest pain is this? Is there left-sided chest pain and retrosternal? Yes, so that's 1/3. Is the chest pain, thank you. Is the chest pain aggravated by exertion? No. Can we see it aggravated by coughing or lying flat? Is it relieved by rest or by nitroglycerin? Hello? No. So by that criteria, this is non-cardiac chest pain. Okay, by that criteria, this is non-cardiac chest pain. However, we'll come to find out that this is actually not cardiac in terms of not myocardial infarction, but this turned out to be an acute pericarditis. An acute pericarditis. So why do we say acute pericarditis? It was aggravated by lying, relieved by sitting up. So nuggets, chest pain, aggravated by lying flat, and relieved by sitting up is more likely to be pericarditis. It could also happen in heart attack. So let somebody know, I say, no, it is not heart attack, be going. What must you do when somebody comes with chest pain again? What's the first thing you must do? ECG. So great. This was the ECG of the patient. And on this ECG, we can see something very fantastic. This is called a PR depression. The PR segment is low. Can we see that? Can we all see that? For those at the back, there are some screens by the side that you can also look at. We can see the PR segment is lower than the TP segment. So this is the TP segment, and this is the PR segment. It is low. So we have PR depression. We have some ST elevation all around. But if you look at this ST elevation, can we see this ST elevation here? It's like a saddle, like somebody can sit down on it. So that's what we call saddle shape. This is a real life case that we managed about 6 months ago. Saddle shaped. So back on your algorithm, you will see on that your manual. If you open your book now, you will see this slide again. You can see in number C, the ST segment is elevated, but it is saddle shaped. That is why we're looking more at pericarditis. The ST segment is elevated, but it is saddle shaped, but you cannot swear. What must you do next? ECG has ST elevation. What must you do next? Positive ECG must do next what? Troponin. Is this patient high risk, moderate risk, or intermediate risk? Very high risk. Why is he high risk? Hypertensive, and he has had a stroke. So it's very high risk. This patient, you should think of MI first. Even if the ECG is normal, you must still go ahead because it's very high risk. But we did the troponin. Where is troponin? Troponin was normal. Can we see the troponin? Normal. So remember our algorithm again. Negative enzyme, positive ECG, could still be MI, or it could be pericarditis. Why can it still be MI? If the patient came immediately, it happened, the enzyme may not have risen. You must repeat that enzyme within 6 to 12 hours. So don't say that you did troponins now, it was negative, come and be going. keep that person, especially those people at high risk, and repeat again within 6 to 12 hours. Yes, troponin is a costly test, but yes, it saves lives. Let them not use you for WhatsApp like they did. I felt very sad because that hospital is a very good hospital. I know the cardiologists there. They are fantastic people. Okay? Let them not use you to gain popularity, cheap popularity. Okay, so check again the troponin in 6 to 12 hours. Let the person say he doesn't want to do. So that when they are telling the story, they should also add it there. So check the enzyme in 6 to 12 hours and be sure you're not dealing with an MI. So final diagnosis was an MI. Okay? We did bed rests, NSAIDs, antibiotics. We gave oxygen, of course, it was breathless. And by day 4, he did not need oxygen again. ASR had reduced, white blood cell count had reduced. And this was the repeat ECG. Can we see the repeat ECG? All those things are gone by day 4. And the patient went home and lived happily ever after. All right, so I'll have to go fast. You will get this in your slides that you receive. Please make sure that you register with your email and that your email is legible so that you can get the slides. If you do not put a good email, you may not get the slides. So we will send you all the slides. Don't worry, have them, share them, let people know the knowledge. But if you want to represent them, please give us credit. Okay? I will leave some of the higher stuff for later. So chest pain nugget 2. Cardiac enzymes are invaluable in the evaluation of chest pain. If you did not have cardiac enzyme in that case, you had ST elevation, what will you think? MI. You will start loading with tropidogrel, everything, jacking the person, and God help you, you gave tenecteplase. Place. Okay? There's a company there, Healthline, that is deals with tenecteplase Place also. I think a generic version, very good. So it's expensive, but it's quite good. And God help you get them. So you must get cardiac enzyme. Please and please, we want you to become advocates. Get to your hospitals. ECG must be there. If you don't have cardiac enzyme, and Codex can give you a deal, I'm sure. Codex, are they there? They can give you a deal, I'm sure. But if you don't have that, make sure you have access to a hospital where you can take the blood sample and send. If you are within this environment, you can send to us. We can email you the results immediately within 15 minutes of getting the sample, so that you can take a decision. Is this an MI or not? If we did not have the troponin in this case, it would have been difficult to differentiate. Okay, I will skip this case because of time, and then I will go to this last case. 65-year-old man presented with chest pain, retrosternal chest pain. It came 12 hours before presentation and 2 hours before presentation. It was aggravated by walking, and it was relieved by omeprazole and by resting. There was no radiation. He also had dizziness, palpitation, and feeling of weakness. No hypertension or DM. But when he went to the source of referral, the blood pressure was elevated, and they started him on amlodipine telmisartan. So who knows whether he was hypertensive before. But he said he has never known to be hypertensive. He does not smoke cigarettes or marijuana and does not drink alcohol. It was referred to cardiocare for cardiac evaluation because they were not sure. They just said, okay, we don't know what this is. Go to cardiocare, let us see. Pulse was 98. Blood pressure 135/84. Sorry, this SpO2 is wrong. SpO2 was normal. This is from the previous case. SpO2 was normal. So what kind of chest pain is this? What kind of chest pain is this? Be bold. Don't be afraid. Yes? Somebody say typical. Eh? Typical. Anybody else? Typical. Why do atypical? This is our slide is showing something else. Showing from the previous presentation. So why do we say is atypical or typical? Let's look at it again. There's retrosternal chest pain, criteria 1. Aggravated by exertion, criteria 2. Relieved by omeprazole and rest, criteria 3. Typical chest pain. This is red flag number 1. Number 2, he has an elevated blood pressure. Somebody asked a question about one-time elevation of blood pressure, and I told you it's very unlikely. The blood pressure is elevated, and he had to be given 2 drugs from where he was referred from. That tells you the patient is likely hypertensive. Okay? I hope this helps. So, hypertension is there. That moves him to, is that moderate risk, high risk, or low risk? Eh? Moderate. One risk factor is moderate, not so. Does he have any other risk factor? Just that. One risk factor, hypertension, Abi. So moderate. What should we do next? ECG. Look at his ECG. What can we see there? What can we see there? Anybody? We can see that there's ST elevation here. V3 and V4. V2 small, V3, V4. Can we see that? You can see the T wave upside down. Can we see the T wave that's upside down? T wave is upside down. From V1, V2, V3, V4, T wave is upside down. So we have an abnormal ECG. So follow your algorithm. Go back to your algorithm, please. Go back to your algorithm. One risk factor with positive ECG. What do you do next? Troponin. Not so? So let's go to our troponin. See the troponin. 11.7. What is the normal troponin? 0.3. His own is not 1 time high, it's not 10 times high. 10 times the upper limit would have been 3. 20 times will be 6. 30 times will be 9. It's almost 40 times the upper limit. And the person was just referred. He came at his own time. He did not even come immediately. They said I should just go. So he came for evaluation, and this is what we found. Hello? So this is a case that can easily be missed. But if you follow the algorithm every time, follow the algorithm. Just follow it. It's there with you. You can keep it. Keep it on your phone. If you join the WhatsApp group, you can see on this thing. We also put the soft copy so you can have it on your phone handy anytime you want to check. Check it again and again and again. So, what is the final diagnosis in this case? Yeah. What is the final diagnosis in this case? Hello? Say it out. You are ACS graduates. Yes. Sign your name, fellow ACS. Yes, what is it? Pulmonary embolism? Acute MI. Correct. So we have an acute myocardial infarction. Myocardial infarction, you need an abnormal ECG, you need elevated enzymes, and you need a setting of acute ischemia. What is the setting of acute ischemia? Chest pain. Somebody coming with chest pain. So sometimes there's a case I had to skip. A 16-year-old came. She had severely elevated enzymes, but no chest pain. She's been having that for 2 weeks. That was not acute myocardial infarction because there was no setting. We gave her medications. We started. 2 weeks later, it was still elevated. I don't know whether Dr. Lekon remembers that case. 3 weeks later, it was still elevated. It was a myocarditis. So, in that case, a myocarditis is damaging a virus is damaging the heart muscle and raising the enzymes. No chest pain. She just came with difficulty in breathing. Exertional dyspnea. Anytime she walks more, she gets tired. So, those are people that will develop heart failure in future. And people will say, I am dilated cardiomyopathy. So, she developed that. She went to the US. They did all the tests, everything. They arrived at the same diagnosis we arrived at. Okay? So, it's quite important. So, if you have elevated troponins, if there is no acute ischemia, we call that acute myocardial injury. And that can happen in heart failure or myocarditis. If there is acute ischemia, then we say acute MI. And you know the different types of MI. If the troponin level is elevated and stable, it could be chronic myocardial injury, like this young girl I talked about. It remained high for almost 2 months, despite steroids, despite non-steroidal agents, it remained high. We call that chronic myocardial injury. So in this case, remember, I'm rounding up. Chest pain is the most common presentation of MI, but not everyone with heart attack has chest pain. Please remember, some people don't have chest pain. They just come with heart failure. They come with pulmonary edema. There are just crepitations everywhere. They come with arrhythmias. They come with silent MI or sudden cardiac death or cardiac arrest. Anybody that has cardiac arrest must have an ECG. You are trying to do hernia, you're trying to do appendectomy. They have cardiac arrest, you resuscitated them. Please have a full evaluation for them. You don't know what, that could have been a presentation of MI. Some of the patients that had diabetes presented for the first time with an MI. They did not know they had diabetes before. Now, the examination is typically normal. The only thing you might find is tachycardia or hypotension. So frequently, examination is normal. Like this case, even SpO2 was normal. And we showed you about the ECG. The SC segment is elevated, or just like here in STEMI. Okay? I'll move fast now. So how do we treat? How do we treat MI? The MI has landed in your doorstep in the middle of the night. Where's that, my senior colleague? In the middle of the night, you have nobody there. You are 30 kilometers from an ICU. What do? In the middle of the night? Please remember that time is muscle. The more time you waste, the more amount of heart muscle is dying, and the worse it will be for that patient. So you must start treating early. You must know what to do, and I'll tell you what to do. So typically, patients should try and get early response and reperfusion therapy. Get to a cath lab as soon as possible. If you are within reach of a cath lab, like Cardiocare, we're not far from here, and some of us can have time, we can go to Cardiocare. Get to a cath lab so that we can get to the heart and open up the blood vessel and put a stent. Sometimes people have come. I think the earliest we have had somebody is 12 hours, but most people come 3 days, which is quite late. That's one of the reasons we say let us teach about this. Okay? But after 12 hours, it becomes very difficult. We have to stabilize first before we go in, because there's a lot of problem. Before 12 hours, you have a lot you can do to save that heart. And these are the goals of treatment. Time is muscle. Restore coronary blood flow as soon as possible. Treat any complications and reduce them. Reduce morbidity and mortality. Patients die. They can be talking to you perfectly fine, and the next minute they're having a cardiac arrest. Never assume that an MI is normal. There's a place I went to teach after I taught. The patient, I think, was a Pakistani. He came only with epigastric pain. Looking like ulcer. But I had taught somewhere, and somebody did an ECG immediately, and he had the elevation of the MI. And they referred on time. I really want to appreciate that hospital. I can't remember the name. I think they are here. Yes, thank you. They raised their hand. They referred on time, and we rushed into the cath lab. Those people, they went back to Pakistan after we put a stent, and they bought me something. I don't know what it is. It looked like I don't know. And one funny coffee. I've never drank it. But it was very nice. They were very happy. So the patient presented only with epigastric pain that had some small radiation to the chest. That is why we said everybody. We've had several patients with query ulcer. In fact, the last patient I treated as an SR before I left UCH, that was about 8-9 years ago, was a professor. He was doing the exam. I don't know who swore for him during the exam. He was doing the exam, and he kept on complaining of, he was actually a former VC, complaining of epigastric pain. They brought Gaviscon, they brought, after a while, he just said no, they should take him to the A&E. He had to stop the exam, and that's the last patient I remember. I gave the patient Tenecte, please, because we rushed the patient to the A&E. It was picked immediately. We took to the ICU, and we gave thrombolysis and opened up. The next day, the ECG was back down. Fantastic, and then he could now go back. So you must recognize it. Everybody here, nobody should miss it. Nobody should miss it, and we will show you that you can read the ECG very well. So immediately do a 12-lead ECG. You are. Don't say that patient cannot afford it. You must have an ECG. Hello? Hello? No shortcuts. You must have an ECG. Everybody, every nurse, every doctor must know how to do an ECG. If you don't know how to do an ECG or to, please, go and know. Maybe I should tell them this here. They used to come for this. Maybe I should tell them we should be checking that one when we are renewing license. You must not do an ECG. Check it. Wherever you are, do the ECG. Now, you know the good thing about an ECG machine, I had hoped that we could get a vendor that could sell ECG machines. An ECG machine, is, especially the ones that are computer-based, is cheap. The only consumable you may use is the gel and maybe the paper. That is all. So if the patient cannot pay, leave it to God. The other people that will pay, do you understand how cheap ECG is? As it doesn't cost more than that gel and the paper. And if it's computer-based, you don't even have to print. You can look at it, please. Or at least if you put your patient monitor, a lot of our patient monitors in our hospitals, but we're not using them. Put it there and at least look at it, but you need a full 12-lead ECG. Okay? Now, once you make the diagnosis like we have done now, start ECG monitoring, insert a cannula, get specialist inputs immediately. Now, join a WhatsApp group so that you can get advice. You can put it up. There are about 6 cardiologists in cardio care. One of us will be awake, hopefully. All of us should not be sleeping at the same time. One of us be awake and can at least assist you. So join the WhatsApp group. You can put the ECG there if you are not sure, but I assure you should be able to read it. Do your enzymes and then then start with your aspirin and clopidogrel, unless it's contraindicated. Okay? You can call cardio care within, but make sure you follow this. This is what you must do. First, medical management. Everybody that has an MI must have. Please don't forget this. I want you to write this down. Keep this in your mind. It's not meant to be forgotten. If you don't remember anything in this ACS, please remember this one. Nobody should have sudden cardiac death. Nobody should die because of MI. At least nobody that sees anybody here. And you know what to do that you can remember. When we send in the slides, catch, if you are the medical director, good for you. Catch your staff and start teaching. If you're not the medical director, call your nurse. If you're the nurse manager or the matron, call them, teach. Anytime you teach, you get better. I've taught this thing at least 30 times. The more I teach, the more I get better. That's why I know it a lot. Abi? So catch some people and teach. That's how I started teaching ECG. The medical students that were in my unit, I saw somebody that was my medical student. The medical students that were in my unit, they really enjoyed. Because when I read, I catch them, whether they want to hear or not. Till 11 p.m., we'll be teaching. Okay? So it was good for me. So catch somebody. So pain relief, oxygen. Don't give oxygen if the SpO2 is normal. It worsens the outcome. Hello? Don't say he's breathing. Check the SpO2. If it's normal, don't give oxygen. So SpO2 less than 94, 94 and below, you should be consider 93 and below, you should consider giving. Give nitrates. Okay? If you know what to do, give nitrates, except the patient has inferior MI or the blood pressure is low. Give antiplatelets. In antiplatelets, you want to give aspirin. Don't say the patient has ulcer. Hello? Ulcer is not a contraindication to aspirin in MI. Can we say it together? Ulcer is not a contraindication to aspirin in MI. Let them have their ulcer after, but let them be alive. If you like, you can give omeprazole or gas afterwards. That aspirin, want them to chew it so that it works fast. We typically like to give, 300 milligrams, that is 4 tablets of the baby aspirin, 4 tablets. That baby aspirin, you give 300 milligrams, they should chew it. The clopidogrel too, 4 tablets, typically. Once you are sure of diagnosis, if you are not sure, please don't give. Check so that you don't worsen an aortic dissection. Or once you are sure of diagnosis, please give. Then beta blockers, anticoagulation, and get ICU and specialist care. Okay, in every town, there is typically a cardiologist not far. There's an FMC near, there's something, at least Nigeria has tried to an extent. And even then, you have access to us through the WhatsApp groups. So we can assist you wherever you are by the grace of God. When patient is alive, we can talk about other things. Okay? This can go a long way to save a patient's life. Just these simple things. Even if the patient does not have money for any other thing, this alone will alter the patient's mortality benefit. Now, early reperfusion. If that patient is presenting within 0 to 12 hours, you need to consider immediate reperfusion. Either you get them to a cath lab, which is the best standard, so you can get them to cardio care as soon as possible. If you are in Lagos, you can get them to any of the centers that has a cath lab there as soon as possible. That is the preferred one. If you cannot get them, then thrombolysis should be done. Alteplase is there. I think Boringa is going to join us. Are Boringa here yet? Alteplase is there. And then tenecteplase is there. Boringa also has tenecteplase and Healthline that is at the back. Please try and get one in your vicinity. We typically have Alteplase and tenecteplase in our facility in case any hospital needs in the whole of Abuja. It's very expensive. So people don't like to stock it because if it expires, it's about 400 or 500,000 or 300,000, I can't remember. If it expires on your hand, you know what it means. Okay, so, but we have one that at least anybody can come and pick and use, and then, you know, when it is. So because we have more patients with MIs. So you can use this one in the interim pending. Each patient cannot afford it. The house usher. And the patient cannot afford it at all. Then consider streptokinase. I don't like streptokinase. It has so many problems. I've had a terrible issue with it. Can cause severe hypotension, can cause severe reactions and all of that. So this is, the patient can truly not afford it, or you have no access to the proper drugs. Alteplase should be around 600,000 or 500,000 for the vial. This other one, if it is a generic one, is about maybe 300 or 400,000, I don't know. They can tell you at the back. You can meet them. Now, if you get to the cath lab, we put in a catheter, we do the angio, we find out where it's blocked, and we put in a stent. And then we open this up. Now, it is late presentation. They've come after 1 day, 2 days. Still, medical management, start this immediately. It's 3 days later, they are still complaining. You may not be able to give thrombolysis again. After 12 hours, you cannot give thrombolysis again. The risk outweighs the benefit. You will get more bleeding, stroke. If you are going to give thrombolysis, please make sure you get specialist inputs as much as possible, and thank God for phones, so that you don't run into trouble. Please and please. Even when we are giving it, it's not everybody that used to give it. Even among us SRs, they used to call, there are bigger SRs. You know, you call them to say, oh God, I won't give thrombolysis. We'll come and stand with you. Okay, so this is what you'll do. So if it is late presentation, angiography and PCI may still be done, but they may need to be stabilized first. But you must still go ahead with medical management, which happens for all of them. Then follow up, beta blockers, AC inhibitors. Sometimes there's nothing we can do. In MI, 50% of patients don't get to the hospital abroad. That is the people that have 911. Chest pain, 911, 50% will not get there. Not our own, no. 50% don't get there. So you can see how high. Of those that get there, the in-hospital mortality is as much as 25 to 38% in a lot of centers. With everything, insurance, cut, everything is there. So you can see it's not something you should joke around with. Sometimes they are there, somebody is saying they have pneumonia, they have some chest pain, they're not getting better. Please and please. Or also they're not getting better, you have given, please do your ECG, check your enzymes. It's better for the patient to spend money unnecessarily than for the patient to spend money on funeral. Okay? So this is very important. I will have to stop now. Again, Monash, ABC, morphine for the pain, oxygen if needed, nitrates. Don't give if there's inferior MI or hypertension. Also, before you give nitrates, ask, have you used Viagra recently? Don't be afraid to ask. Please, there are so many things that they are selling in the pharmacies these days. Ask, call the person, just ask everybody, please wait. You know, sometimes the whole family is there. Don't ask for the son, please. Just ask them to wait outside. Okay, how far, anything. You know, please ask. If you give the nitrates and the patient has had sildenafil or tadalafil before then, you will have hypotension that you cannot come out of. The blood pressure will slam down. You are on your own. So please ask before you give it. Then your aspirin and clopidogrel. If you have other ones, prasugrel is better, but it's very difficult to find. Statins and heparin. Please give them. The statin we are giving is a very high dose statin. If you are giving atorvastatin, that is a Lipitor brand for Novartis, is 80 milligrams we give, 80. If you are giving rosuvastatin, is 40 milligrams we give for acute coronary syndrome. Okay? And then you will still have to give some heparin or clopidogrel. It typically helps. This is what you need to do first before referring the patient. Get specialist input as soon as possible. MI kills. Okay, so I will show you what it is. This is cardiocare. I will show you how we do the procedure. This is cardiocare, where we do the procedure. That's us in the cath lab. I'm doing a case recently. And this is us with some residents and consultants teaching. So we just do that. You can see how we puncture the vessel. Very simple. You can do it, Abby. It's like doing a venopuncture. Then, after we do that, we pass our catheter in. We put a sheet into that femoral artery. We pass our catheter in. The patient is awake. There is no anesthesia. The patient is awake throughout. We just do local anesthesia around where we give the injection. Then we give a dye to see where the blockage is, like this. And then we give a dye also to see both the left and the right side. In this case, this was a 42-year-old computer operator. You can see where the narrowing is. Can we all see that? It's very clear. And so we pass a wire across the narrowing. That is us passing the wire. It's a very complex procedure. It's not very easy, but it's very, it's relatively easy. We pass the wire, then we pass a balloon across to open up the blockage a bit. After that is to prepare the lesion. Then we come over with a stent. The stent is a wire mesh. It is typically drug-eluting. There are drugs embedded on it. So it now stays there and keeps it open. This stent is there for life. We're not going to take it out later. This is how we inflate the stent. It's not a syringe we use, but it's a measured atmospheric pressure. Okay, so you can see us inflating the stent. Can we see the balloon there? We're inflating the stent to open up that blood supply. Then we can check after we are done. And you can see the narrowing is gone. Can we see that? The blood supply is gone, MI has ended. Okay? Typically, patient 24, 48 hours, they can go home when we watch for complications and all of that. So you can see that that is how it is done. This is the ideal. If you can get the patient to do this within 30 minutes, best. 1 hour, best. 12 hours, best. But if you cannot, you may start some thrombolysis initially if you are far away and you are sure of diagnosis before we do that. This is another case. We've done over 500 cases of different interventions in cardio care successfully by the grace of God. Okay? That patient I talked about, remember the patient we talked about, the story we've just given, and his ECG, he had 85 to 90% left main stenosis and 85% mid-segment LAD stenosis. He had 2 stents, procedure well tolerated. He was transferred to ICU, and then he was later discharged. This was the ECG representation. You remember? Can we all see that? With the S elevation and the T wave inversion. This was the ECG 4 days after. Can we see the ECG after? The heart is coming back, and it's still telling us, thank you. And he lived happily ever after. Thank you very much. I would like to take any questions if there are. I would like to take any questions if there are. We've had to compress a lot of stuff in a short time. So please, do you have any questions? I cannot go through everything, but you will get a lot of the slides. You get all the slides, and you can watch the video again. We have also webinars that we have done on chest pain and MI on our YouTube channel. You can go and watch them, rewatch them again, and we can take it from there. Any questions? I think we can take 2 questions quickly. 2 burning questions on chest pain. Yes, sir.
Thank you, Dr. Iseko, for that beautiful presentation. Please, what is the difference between acute myocardial infarction and ischemic heart disease?
Okay. Thank you very much. Okay, so I had a slide for that, but I could not go through it. So ischemic heart disease is the condition that is the umbrella condition. Every single condition whereby there's reduced blood supply to the heart muscle is called ischemic heart disease. Every time there's reduced blood supply to the heart muscle, ischemic heart disease. This comprises from what we call an acute coronary syndrome to a chronic coronary syndrome. Chronic coronary syndrome typically consists of what we call chronic stable angina. The patient has chest pain, he stops. He does exercise, he relaxes, he gets better. My wife went to do her hair in the hair salon, and somebody was complaining that anytime she climbs up the staircase, she has chest pain. But when she was asking the other people in the hairdressing salon, somebody said, she knows that thing, that you need to be drinking Coke. Real life story that you need to be drinking Coke more and more. I don't know what's happened to that woman. Okay. So they say you need to be drinking Coke. That you just drink Coke. Anytime you come, just drink Coke. It will go down. Okay, so that's chronic coronary syndrome. It used to be called chronic stable angina. Now it's renamed chronic coronary syndrome. Now, under the acute coronary syndromes, we have acute myocardial infarction, which may be ST elevation and non-ST elevation. And then we have unstable angina. So those are the ones under the acute coronary syndrome. So the umbrella is ischemic heart disease. We have acute coronary syndromes, and we have chronic coronary syndromes. Chronic coronary syndromes are typically chronic stable angina. They are fine otherwise. Only that when they walk, when they have sexual activity, when they change a tire, when they do something, they have chest pain. When they rest, it goes away. They say it's nothing. Almost all the patients that we see with MI tell us that they've had that for over 2 years before. They thought it was nothing. Somebody said you should drink paracetamol. Our different stories, or they have been drinking omeprazole. It just that it's not working again. Now the acute coronary syndrome, MI, or unstable angina. And the MI could be ST elevation or non-ST elevation. How do we differentiate acute ST elevation MI, non-ST elevation MI, and unstable angina? How do we differentiate them? By those simple 2 tests. What are the 2 tests? ECG and troponin. In unstable angina, you typically have, you may have an ECG that is neither here nor there, not characteristic diagnostic, and the enzymes are negative. Once the enzymes are positive, you are dealing with acute MI. If there is ST elevation, we call it ST elevation MI. And if there is no ST elevation, we call it non-ST elevation MI. Okay? So that is the difference. I hope that helps. Yes, somebody there. Please ask any question that you have, either from this or from any area of cardiovascular medicine.
Thank you, sir.
Or medicine at all.
Sir, please, I would like to ask for a patient that comes in with atypical chest pain, atypical or a cardiac pain, and the ECG is negative. Do you still need to do troponin? Do you need to assay for the enzymes?
Okay, thank you very much. Okay, so let's go back to our algorithm. Can we go back to our algorithm? Atypical chest pain. What do? The first thing is what? You find out the risk. What is the risk level of the patient? If the patient's risk level is high, you must do troponin. If the patient's risk level is intermediate, then you can leave to your clinical judgment. If the patient's is low or no, then it depends. You can now manage. So if you have atypical chest pain or non-cardiac chest pain, it doesn't mean it's not MIO. It just helps you to know how to help. Now, if you now do that and the ECG is normal, atypical chest pain and has low risk, use your algorithm, low risk, normal ECG, you should do what? Exclude other causes. However, remember what we said. If the patient is still having ongoing chest pain, what should you do? Repeat within 6 to 12 hours that troponin again. I mean, either the ECG or whatever. So you may consider doing the troponin. So that is the place where we say either or. If the person has 24-year-old, no hypertension, no diabetes, ECG is normal, no previous risk factor, no risk factor, atypical chest pain, then you may or may not do troponin. In our center, we do troponin for everybody. Okay? So if there's now financial constraints, insurance said they're not going to give you approval, then you can be arguing like that. I hope that helps. That helps. Okay. Please.
Thank you for the presentation, Chief. My question is regarding the use of aspirin and clopidogrel. So there's been this conflicting thing we've been seeing around in practice. So people tell you that once you're using the aspirin, then there's no use to use the clopidogrel, and some others say use clopidogrel if you don't want to use aspirin. So I don't know if you can clarify, is this something that we have to use both, or one is enough, or either is enough? Thank you.
Thank you very much for that question. Please ask questions, because I'm sure when you ask the question, it's in other people's mind. Okay, so in terms of aspirin or clopidogrel use, number one, all patients with hypertension should not be on aspirin. So sometimes we see everybody because of Zebudiah's advert. Abi? Remember that Zebudiah advert? So doctors even are following that Zebudiah advert. Not everybody. Remember the algorithm that Dr. Oladekon showed, and many of those people with higher risk that you are thinking should have. I think Dr. Officer will shed some more light on that. Now, when you now need to put an antiplatelet, yes, a lot of times we typically try to use either aspirin or clopidogrel. However, there are cases when you have to use both of them together. MI is one of them. Anytime you have an MI, you need to use both of them together because they work in two different pathways to block platelet activation. Okay? So, and aggregation. So, for MI is one of them. Another reason why you use both of them is if the patient has had a stent. When we put a stent in the patient, they need to be on dual antiplatelets for at least 6 months to 1 year. So they'll be on dual antiplatelets for 6 months to 1 year. In those cases, those are the ones that will use dual antiplatelets. Sometimes some people still use dual antiplatelets. The patient has peripheral vascular disease and they are unable to get peripheral angio. But I advise you, get a peripheral angiography and find out what the problem is. So if you come to our lab, we will do the peripheral angio, and if there's a problem, we can, because it does not prevent, it does not all totally stop the problems. Okay, so this is where some of the things we need to know about. Okay, I hope that helps. Yes.
Thank you very much for your presentation. Regarding the management, the medical management for the pain relief, I recall that there were different schools of thoughts regarding the use of morphine. Some supported its use, whereas others were against it.
Going to worsen it. Why? NSAIDs are going to cause constriction of afferent arteriole and increase intraglomerular pressure. Okay? That will be a problem. So that could worsen your blood pressure control. That could worsen outcomes. NSAIDs will also cause retention of fluid and worsen cardiac function. So we don't like to use NSAIDs. If you don't have morphine, then you can think of the other ones. So the typical thing is to give an antiemetic and then give, morphine is typically preferred. Gives all of those. Now, there are some people that do not tolerate morphine for one reason or the other. Those are the ones that you can choose. So I don't know if anything has come out about morphine. I'm not aware. Okay, so all the panel in front said they've not. So we don't do that. Morphine is the preferred one. Now, morphine is a controlled substance, so it's difficult to get. And in your hospital, it's probably under lock and key, just like it is in ours. Okay, and one of them is very expensive, as in extreme, either the syrup or the IV. The syrup is very expensive, very, very expensive. So I think you can give the IV, but make sure you give an antiemetic. Otherwise, the patient will start vomiting in front of you. So typically, we give antiemetic before, and then you give your morphine. And it typically helps. It helps outcomes. That is why it's part of the standard guidelines. Okay, are there any other questions? Any other burning questions on chest pain? So right now, we have established that anybody with chest pain will know exactly what to do. If it is an MI, we know what to do. We know how to differentiate one form of chest pain or the other.
The full first ECG was designed in 1903 by physiologists, and apparently they didn't have limb leads. They didn't have the limb leads or the chest leads. Yeah. So what you do is that you put your two hands inside a bucket of salt water, and your left leg too in a bucket of salt water, and the machine now measures the action potential that's generated.
Now, about 5 men have to actually carry that
actually,
machine,
you need
right?
about 5 people.
As opposed to the portable ECGs we now have now, right?
Yes.
So everybody should have an ECG in their hospital.
Exactly, and we don't have any reason not to know how to read one.
Exactly.
All right, so moving forward, for those of
So she was tested positive for malaria, and her fasting blood glucose was 138 milligram per DL. She was then commenced on malaria treatment and was commenced on metformin and glimepiride. Her condition improved and she felt better. So based on what we've said so far, which
diagnosis has been established, the testing was appropriate, medications were appropriate, there's a low risk of hypoglycemia, and all of the above. So there's a poll.
Poll, if you can just go to the poll. Okay. Sorry. Yeah. So let's get our polls in. Let's get our answers in.
Is it coming up? Yes, we'll leave it there.
Okay.
Okay, so what do we think is the most correct answer in this case? Option B, that testing was appropriate. Option C, medications were appropriate. Option D, hypoglycemia risk is insignificant air. And then option E, option 5, all of the above. Any thoughts from anybody? Anybody interested in trying to attempt the question can raise the hand
Yes,
until I get the poll up. Thank you. Who wants to answer? Who wants to try? I think it's a very short case scenario.
They didn't see the case.
Okay, do you want to go?
You want to see the case again? Okay, I'll just go back.
Okay, so we have this patient's air. That means we didn't concentrate on the first slide.
A 50-year-old trader that went to the hospital because of malaria, chills, and headaches of 3 days duration, for which she was given paracetamol.
Okay, so just scroll to the poll now.
So, this is the poll.
Next.
So, our answers.
Let's leave it there.
Okay.
Okay, I think we just have to go on. So it's coming on. That's great. Okay, so let's try. Let's attempt. Let's engage the poll, please.
Okay.
Let's engage the poll. Let's engage the poll. Let's engage the poll. Just 10 people so far. There are tons of us in here. Okay, so she came to the hospital with symptoms that looks like symptoms of malaria, and she indeed tested positive for malaria. But our fasting blood glucose was 138 milligrams per DL. The threshold for that is 126 milligrams per DL. So that's clearly above the threshold. And then she was treated for malaria and then commenced on 2 anti-diabetic medications. Okay, so thank you for attempting. So the largest answer says that the testing was appropriate in this scenario, which is great. And then the next most popular answer says that the diagnosis has been established. Okay, thank you very much for attempting the question. I think over the course of the presentation, we'll be able to decipher what. So next slide.
Okay. So a week later, her husband noticed she was unresponsive as he tried to wake her up from a prolonged afternoon nap. She was then rushed to the hospital, and her ACS on presentation was 11/15 with an RBG of 2.4 millimole per liter. 50% dextrose water was administered, and she gradually regained consciousness. Her husband realized she could have died, and she was very angry. So what are your thoughts?
Okay, so I think this case scenario, this is a real life case, okay, and I think there are many things we can learn from this case. I want to believe that we all have our thoughts of this case, about what the questions posed to us initially. And yes, it's important to screen for type 2 diabetes. We should not wait for symptoms before we screen for diabetes. If we wait for symptoms before we screen, we'll have a lot of complications in our hands. So it is to utilize opportunistic screening. So if you have a patient that comes to your hospital for whatever, and you ask the patient, particularly once the patient has some factors in which we want to screen, we'll talk about that on the next slide. So we should screen for that. And of course, we should be alert to the, is it echoing? We should be alert of diabetes. That's the common symptoms of diabetes: fatigue, polyuria, polyphagia, neuropathic symptoms in the extremities, blood vision, or someone is just sick and then the recovery is quite slow. Anytime we see any of this, we should. So that's like symptomatic. But people can also be asymptomatic. And these are the people in which you want to screen, even if they don't have any symptom. So a 42-year-old man comes to your clinic with back pain. Part of your general question: have you been diagnosed with diabetes before? Have you had a sugar test before? If you say they've not been checked before, you should advise them to check. So those are opportunistic screening. And then if you have any of all these other risk factors there, family history, hypertension, dyslipidemia, previous history that suggests GDM, obesity or overweight, which is quite common, sedentary lifestyle, people on medications that are known to be able to induce diabetes, that's your diuretic, steroids, etc. And of course, previous history of any abnormal glucose test in the past, or if you have a patient that has PCOD. So those kind of patients we should take. So in this case scenario that we described earlier, it was appropriate to check for diabetes in that scenario. So that's screening. Okay, but we should understand this criteria. And I think that's one of the questions that was posed by the poll that we asked for. So now these are the criteria, but like they always say, the devil is in the detail. The devil is in the detail, okay? And the third point here says that in the absence of unequivocal hyperglycemia, that the diagnosis does require 2 tests, okay? So if you just have a mild elevation at 138, yeah, a person could have diabetes, but it's probably, you probably should, okay, so you probably should check on another day, okay? Either you check on another day, which is preferable, but beyond that, you should also get an A1C as well. And I'm happy that A1C is quite widely available now. It's presented about the Clover A1C machine as well. So check another day, particularly if the levels are not gross. Now, the one that is unequivocal is one that is markedly elevated. Maybe you're getting like 160, 170 for a fasting glucose. That is not debatable. But even still with that, I would suggest strongly that you get an A1C to back it up. That makes your diagnosis more robust, and it will make your treatment initiation to be more precise, okay? So you're less likely to overtreat or to undertreat, and we are less likely to send people to early graves by causing iatrogenic hypoglycemia. So why do we need an A1C? It helps you to confirm the diagnosis. Now, the drawback of telling a patient to come action of them will disappear. That's the truth. They'll just forget, okay? And that means you've lost them to follow up. But if you can get an A1C on that same day, and it does confirm that the person is within this range. And we should not forget that the A1C reflects sustained hyperglycemia. Why? Because it takes 3 months for the A1C to reflect. So it reflects the level of glycemia over the preceding 3 months. And of course, it gives you a baseline. All the studies that are done for diabetes management, all are targeted towards A1C. So because every fasting blood glucose can vary quite widely from day to day, okay? But that woman that got 138 on that day, you don't know whether the day before it was 99 or 104 or 160. You really don't know. But A1C averages that out over the last 3 months, okay? And it can guide our treatment initiation and escalation. Now, we have an algorithm inside our booklet, which we adopted, okay? But we should know that the algorithms from which this was adopted was actually based purely on A1C. But we also included glucose ranges there just to give guidance, particularly for practices that don't have A1C readily available, okay? And if you follow this algorithm for this patient we talked about, first of all, the FBGC was less than 140. It was 138. And that means this patient is a good candidate for just lifestyle treatment only, okay? Now, you can have some patients that are at 138, and maybe the A1C is greater than 7%. then you probably should consider the patient for medications. And even in that case, if you indeed needed to use medication, you probably should be considering monotherapy rather than dual therapy, okay? And as I said, the A1C is actually much more accurate in guiding that rather than your glucose readings alone. And we did put that we're talking about average fasting blood glucose, so it assumes that you have checked it on more than one occasion. Just testing someone's sugar at one occasion, grabbing the person and putting the patient on anti-diabetic medications is quite inappropriate. Again, except if the level of hyperglycemia is quite gross, okay? Some patients who qualify for dual therapy invariably, okay? And in that case, typically exceeds 8 or 9%. Fasting will probably exceed 160 milligrams per DL. Now, don't forget that diabetes is a state of chronic hyperglycemia. And in the absence of hyperglycemic crises or emergencies, you are not actually under any obligation to bring down the glucose readings rapidly. Not at all. You can take your time in getting it down gradually. That means that if you put the person on monotherapy and you reassess over time and it's not working, yes, you can escalate the treatment, okay? And that's part of the things that we want to emphasize during this, because the case we discuss is a real-life scenario. Now, so I want us to go through this algorithm, and of course, when we are trying to initiate or escalate treatment of a patient with diabetes, we utilize this, and I think we can be appropriately guided. Now, talking about reducing the risk of hypoglycemia, which this patient unfortunately suffered, there's an option on the poll that said that the risk of hypoglycemia is insignificant because it's just an oral agent. That's totally inaccurate, okay? The risk of sulfonylureas causing hypoglycemia is almost as high as that of insulin, so we should be aware of that. And anytime we are initiating medications, you should consider the hypoglycemia risk, okay? So you have a poor old man that's blind, that stays at home alone, that his meals are not regular, or you know what I mean. So when you are seeing the patient, we'll still talk about the risk factors for hypoglycemia, but that always has to be in your mind when you're starting a patient or when you're escalating the treatment of a patient with diabetes. It should also inform us when we're choosing the medications, and it's always wise to start small and escalate the treatment slowly rather than bombarding the patient with a lot of medications ab initio because you want to improve the patient or you want to get the numbers down. So these are all risk factors for hypoglycemia, old age, frailty, malnutrition, multiple comorbidities. By the time you see them, they have heart failure, they have liver issues. Be careful. Acute illnesses. During acute illnesses, there's a phenomenon we call a stress response or stress hyperglycemia, and it can exaggerate how high the degree of dysglycemia, and it can actually give us a false idea of, and that's why, so in stress hyperglycemia, someone may not even have diabetes at all, and the sugar might go up, and that's one of the things that the A1C can help us to tease out. So liver issues, kidney disease, heart failure, dementia, depression, people that have irregular meals. There's some people like that they just don't. Longer duration of diabetes, hypoglycemia, people that have hypoglycemia awareness. Some people are on beta blockers that can blunt the adrenergic response to hypoglycemia, and that can also increase the risk of someone having severe hypoglycemia, because that means the initial symptoms they should experience has already been blunted by medications or otherwise. So alcohol use, sedatives. Some of my colleagues don't even give sedatives to patients that have diabetes or that are medications that have high risk for hypoglycemia. Why? Because someone with hypoglycemia should wake up in the middle of the night because their sugars are going low. They just sleep it off and then they sleep to the other side of the world. It's on to counsel patients that are being started on diabetic medications on hypoglycemia. So we all owe our patients that duty of care. We should discuss the early symptoms and the late symptoms. During my residency days, there was a patient that was brought in the middle of the night with fits, okay, and alter sensorium. His sugar was not grossly low. It was in the range of about 85 to 90, okay, but it was being managed already for a stroke and renal impairment because he did have some CKD actually, and it was already being planned for emergency dialysis. CT scan has been ordered, and we just asked that what was the RBG presentation. They said about 85, and they repeated it again. It was like maybe 69, 70. But lo and behold, by the time we gave the guy glucose, the guy was fitting, unconscious, drinking saliva, oropharyngeal airway inside too. The guy woke up and started talking within like 30 minutes. So hypoglycemia is very common, and The wife later told us that the guy woke up in the middle of the night and was asking for coke, and that she was like, "Why should you take coke? You that you have diabetes," before he slipped into unconsciousness. But that history came later. So not just the patient and the loved ones should be educated about the risk for hypoglycemia and how to manage it. Okay, and those patients that are at higher risk, particularly those that are insulin treated, they should monitor importantly, and also they should have something that they can use to rapidly correct hypoglycemia. In the Western world, people carry glucose tablets around. In patients that are on SU, that's sulfonylureas or insulin, they must always have a sugary drink at home so that if anything happens at any time at the early stages, they can correct it before it gets into the more severe states. So, and of course, after hypoglycemic episodes, even mild versions, because most patients that have severe hypoglycemia have had mild hypoglycemic episodes before. Patients should be taught to analyze the events that led to it. Did I take more medications than usual? Did I not complete my meal? Did I vomit? Or did I have diarrhea that makes sure that the food I ate was not absorbed? Or did I exercise more than usual? So these things are the things that can trigger episodes of hypoglycemia in a patient. So I think that's a summary of the first case, and I hope that the lessons there are well learned for us. So I think I'll let Dr. Obi take us through a second case now.
Okay. For the second case, these are the learning points we're meant to take home at the end of this case. So we have Mr. Kande, a 58-year-old civil servant who was diagnosed with diabetes 4 years ago. He was placed on metformin and glibenclamide and has been compliant with follow-up for the past 4 years. He presented on account of poor vision in his left eye over the preceding days with floating shadows in his visual field, no previous visual problems. He previously saw well without requiring glasses. His fasting blood glucose at presentation was 142 milligram per DL, and his most recent glycosylated hemoglobin, which was done 9 months ago, was 8.6%. So he was referred to the eye clinic where he was diagnosed with proliferative diabetic retinopathy in both eyes, but it was worse on the eye service. Then referred him to the specialist diabetes care to optimize his glycemic control. He was also scheduled for intervention, which were laser photocoagulation and vascular endothelial growth factor therapy. He was given a 2-month hospital appointment for the endocrinology review in a general hospital, but before the appointment could come up, he developed sudden onset chest pain and shortness of breath 2 weeks later. He was then rushed to the emergency room, and the diagnosis of myocardial infarction, the ST elevated type, was made, and he required acute care and hospitalization. He made some recovery, but he continued to have heart failure symptoms, and he completely lost vision on his left eye. So from what we've heard, we'll go at what can we learn from this case?
So any thoughts on lessons from this case? Lessons from this case. So you have someone with diabetes that's had diabetes for a while. He was actually going for follow-up with his doctor, so he did his part, apparently. He developed some high symptoms, and then he was referred to high service. Some treatments were planned. He was meant to have appointments, but even before the last appointment, he suffered an MI, which damaged his heart quite significantly. And to add salt and pepper to his injury, he lost the vision as well in the eye. So what do you think we can learn from this case? Any thoughts from anybody? Lessons. Yes, please. There's a gentleman at the middle raising a hand. Just lessons from this case. Where is the microphone handler? Microphone. I think there's something else. Backslide.
Thank you. From this case, there were some pertinent points to note. One of them would have been the poor glycemic control. As signified by the HbA1c level, which was above target, is medication should have been intensified. His anti-diabetic medication should have been intensified. And also, the physician in charge of his care should have given him adequate counseling on the symptoms that he should have been looking out for worsening of his symptoms, that is increasing severity, as well as he should have scheduled regular follow-ups in order to determine the response to his care. Thank you.
Thank you so much for those answers. I think they were very spot on. So I think those lessons are highlighted, and some other lessons we'll talk about as we progress with the case scenario and this discussion. So I think it's very important to know that diabetes has widespread complications. I think we all know that. Thorough systemic evaluation is mandatory. I think we all know that, even though sometimes we falter in requesting for all the investigations, in doing all the clinical evaluation we should do in terms of question, examination, and investigations. Sometimes we falter because of our busy clinics, but we cannot afford that. And in very busy clinics, checklists can be helpful to make sure that this patient has had this check per this time. And the things that we should evaluate includes diet, physical activity, adherence to treatment, impact of work on life, how the patient is coping and what the patient does, routine evaluation for microvascular complication, addressing cardiovascular risk factors, and we should routinely assess for macrovascular complications as well. So we know this already, but sometimes we don't do them quite enough. We should ask for symptoms of neuropathy and check for signs in all our patients, okay? We should look for features of nephropathy in all our patients. We should look for features of retinopathy in all our patients. Importantly, in that case, like I tell most times, is that by the time you have the feature, previous slide please, by the time we have the features of, by the time retinopathy starts to have symptoms, the cat has left the cage, or whatever term they use for that, it's way too late, okay? It's better treated and responds better to treatment before symptoms, and that's why it is recommended that people with diabetes should have their highs checked annually. Now, we don't do that enough. And from some researches we did, and that they did in UK as well, every other year will suffice for most people, in which the high examination was normal. But anything less than that is totally unacceptable, okay? And the number of people, now diabetes, loss of vision is one of the most feared complications of diabetes, and unfortunately, it is highly preventable. Now, you may not be able to entirely reduce the risk of a heart attack or a stroke in someone with diabetes, totally mitigate. But the microvascular complications actually respond very well to glycemic control. Particularly retinopathy responds early to those measures that they take, the photocoagulation air as well. Complications as a retinopathy already, but I'm not sure that the due date was done. Can anyone remember the blood pressure of that patient? The blood pressure was not stated, and it probably was not checked in clinic. And sometimes when a patient comes with the symptoms that appear to bother them the most, we forget our own agenda, okay? So we should pay attention to cardiovascular risk factors in patients with diabetes. And even if they have, the guy is complaining of serious burning sensation in the foot, he just wants it treated, and then because of that, you just attended to that. You left the cholesterol profile, you left the urinalysis, you left the blood pressure. This is what we get. Okay, so we should see that the cause of death in patients with type 2 diabetes is almost like a global meta-analysis. Sudden cardiac death is up to 30%, heart failure, presumed cardiovascular death. So that's intense, and because of this, we should pay attention to cardiovascular issues in them. So again, over half of the deaths in diabetes patients are due to cardiovascular disease, and I want to hope that we know that traditional treatment for just glycemia alone does not address the cardiovascular risk or the macrovascular risk. And the risk for stroke and heart attack is increased by 2 to 4 times, and we have a role in mitigating this risk as well. So these are cardiovascular risk factors that I'm sure that we are all aware of, and it is important that we identify them and manage them such that we are seeing less of the coronary artery disease, less stroke, less peripheral arterial disease, less heart failure, etc., and less sudden cardiac death as well. So how can we manage this cardiovascular risk in our diabetic patients? It goes back to the basics. There's nothing highfalutin that's required, really. Measure the BP at every visit, treat the BP to target. preferably include a RAS blocker. We should manage lipids in an evidence-based manner. All this, someone that has severe dyslipidemia that you treat with atorvastatin for 1 month, to bring down the cholesterol quite nicely, but immediately you stop it, check it 2 weeks or 3 weeks or 4 weeks after, it's back to where it's coming from. So most of them that require those kind of interventions require it long-term. They're not short-term interventions. Smoking cessation, some of us don't ask, regular exercise and weight controls, and then we should assess other cardiovascular risk factors and make sure that we manage them well. And of course, patient education remains very critical. So that patient that had retinopathy issues and ended up having an MI on top of it, the BP was not checked, the cholesterol was not checked. I know that these were not checked because, at least it was not checked recently and was not managed because, as I said, this is a real patient. And so those things add up to the cardiovascular risk, and it will cause our patients to end up like this, which we don't want. So we have a third case here, which I think let's just take briefly.
Okay. These are the learning objectives we want to take home at the end of this case. So Mr. Waza, a 49-year-old banker who was diagnosed with diabetes 10 years ago. He presented on account of painful sensation in both feet that has been ongoing for a few months, but he came now because it has been worsening. He reports being on metformin and vidagliptin for his diabetes, and he has no history of hypertension. So for this case, how would you proceed? So our poll is up. If we can just log in our poll so that we can get our answers and go.
So we have 5 options there. What do you think is the most appropriate, maybe initial step, so to say? Scroll today.
Okay. So still coming in.
Okay, so thank you so much for the answers. I think we chose the right answers mostly.
Yes.
It's important to examine the feet. It's important to reassess cardiometabolic control. And there's a study that some of my chiefs did in those days that we found out that overall cardiometabolic risk factors correlates with peripheral neuropathic symptoms and signs more than just glycemic control alone. So putting things like hypertension, lipidemia, and other metabolic parameters, it carries more weight than that. So there's not so much time for us to go through this, but I think the most important thing I want to tell us on this slide is that, number one, pre-diabetes is associated with neuropathic symptoms. So the nerves are extremely very sensitive to glucose elevation, so that's one. So patients with pre-diabetes can have features of peripheral neuropathy, that's one. Secondly, is that apart from poor glycemic control, glycemic fluctuations, either going up or coming down, particularly fluctuations, is very disruption to the nerve activities and can make neuropathic symptoms to be very worse. So that's secondly. Of course, we have various types of neuropathic symptoms, the most common of which is the first one, that has a distal symmetric one, which we are all familiar with. And we can have all sorts of symptoms and signs, which we should try to elicit in our patient. Don't forget that the patient will not always report these things to you spontaneously. We should look for it. It's important to know that diabetic neuropathy is the biggest risk factor for diabetic foot ulceration and the biggest risk factor for foot amputation amongst patients with diabetes. It's important we look for these symptoms, we look for the signs, and when we pick them, we should address them as appropriate. And of course, this is the approach. So we should clarify the symptoms, we should examine appropriately, we should look at other long-term complications because these complications don't work alone, they come with other guys. We should try to optimize the patient's cardiometabolic control. Don't forget that when you give the neuropathic analgesics like gabapentin and pregabalin, it just treats the symptoms, it's not treating the drivers. So we need to address the drivers, and then you need to explore other treatment options that you have. These are common differential diagnosis of the neuropathic symptoms in diabetes. Importantly is vascular claudication, which people often mistake with that. So I'll focus on that vascular claudication a bit. Classically, diabetic peripheral neuropathic symptoms is worse at rests. Okay, so the patient feels it worst when they lie down in the night or when they just get out of bed in the morning. That's when they feel it the most. But by the time the patient tells you that they have pain in their feet or their legs, that is worse when they are walking. You're probably more likely to be dealing with vascular claudication, or if it's neurological, then it can be neurogenic claudication. So vascular claudication can look like this. The level of discomfort depends on the level of occlusion. But importantly, it's typically worse with exertion. The patients, sometimes it can be worse at night as well in patients that have rest pain, but that's usually at the very end of it. So when you elevate the leg on the bed, that's vascular supply is a bit further diminished, okay, but classically it's worse on exertion. We should examine the feet in patients with suspected peripheral neuropathy. It's important, and I know that most doctors, most of us don't examine our patients' feet, and I want us to do better in that regard so that we can mitigate the risk that comes along with it. Once again, once you see a complication, once you see microvascular complications, look for the other microvascular complications and also look for macrovascular complications. In this man that had a heart attack, once again, if a thorough evaluation has been done at the time he developed retinopathy, maybe that heart attack could have been prevented. Maybe someone will have seen something on the ECG and put this person on a aspirin, for example, if there were ischemic changes. Or maybe someone will have done the lipid profile and saw that the lipids is not a target and put the person on a statin. Maybe the blood pressure will have been checked and they will have been kind enough to put the person on an ARB or an ACE inhibitor. So this is how to optimize cardiometabolic control again. We are aware of all of this, so I don't think there's any other point I need to emphasize here. And of course, if the symptoms are atypical, just like the symptoms suggesting vascular claudication, please get help. Discuss with a specialist, discuss with a colleague so that we can all be pointed in the right direction. So this is about that man now. The blood pressure was high. The total cholesterol was very high, even though the kidney function was good. We already mentioned the A1C, which was reasonable. Okay, the glucose readings fluctuated. Okay, and I did mention earlier that fluctuations in glucose is quite very bad for neuropathic symptoms. Of course, there was sensory loss to both monofilament and vibration sensation. So this is the way the patient was managed. A dietitian review, diabetes treatment was optimized. It was placed on the DASH approach for hypertension with a plan to commence medication if the BP was not at target within 3 months. It will also be appropriate to start this patient on medication immediately if he chose to, actually. Starting for dyslipidemia, foot care counseling, book for foot cleaning. Don't forget that patients who have symptoms plus or minus signs of peripheral neuropathy have a high risk for foot ulceration. And that means foot counseling is very, very, very important for those patients. Otherwise, they'll come to your foot clinic next month with a foot ulcer, and they'll tell you that they were using hot water or they put the foot on a lantern because it was aching there. And I'm sure we've seen all of those kind of patients before. Or they call someone to come and massage it for them or do something strange, and then the foot will just be all bad. Unfortunately, I have maybe about 2 or 3 on the world currently, which is quite disheartening. One of the ones we have on the world currently was managed for the foot ulceration maybe 4 months ago or 6 months ago. It got better. It was superficial at that time. She went to the village, and then some things happened, and some things happened, and some things happened, and then she's back with another one. Okay, so that's that case. I think we'll take a 4th case, which will be the last one. Try to be fast with this.
Okay, for this case, these are the learning points we need to take home at the end of this case. So for case 4, we have Miss Juliet, a 33-year-old teacher that first presented with marked weight loss, blurred vision, and paresthesia in both feet. She was diagnosed with diabetes 6 years earlier on, and her medications were metformin and sitagliptin, which she took as prescribed, but still yet her blood glucose remained uncontrolled, with fasting blood glucose mostly around 20 millimoles, and she believed her medications were not working for her. On presentation, she was noticed to be chronically ill-looking, afebrile, not pale, mildly dehydrated, aneuric with no pedal edema. Her pulse rate was 90 beats per minute regular, and her BP was 105/75 millimeters of mercury. Her weight at presentation was 56 kg with a BMI of 18.9. Fasting blood glucose done was 286, and an urgent RBG was 394 milligram per DL. So for this, how we proceed? The poll is up. So which of the following is preferred? How we proceed for this patient? Please let's go online and log in our answers.
Do you want to just optimize a diet and reassess in 3 months? Do you want to add a sulfonylurea? Do you want to add glimepiride? Do you want to add a GLP-1 agonist? Or you want to refer for specialist assessment? How old is she again? 33 years old, right?
Yes, 33 years old.
33-year-old woman that does have diabetes for a
For
while.
6 years.
Quite a bit. And then on medications, but the glucose was still quite high. How often do we see this kind of patients that have been on oral agents, but the glucose is still really high? Not just marginally high, but still really high.
So from the poll, a lot of people...
Okay, so I think, again, we are choosing the right answers, which is good.
Yeah.
The patient should be admitted for rehydration. Patient should be sent for specialist assessment.
Okay.
The assessment is probably a preferred answer for me because rehydration alone will not solve the problem. If you rehydrate the patient and you leave the patient still on that same medication, you have not really done so much good. The rehydration you rehydrated, patient will urinate it hopefully within the next 24 hours. So that's not, so the treatment actually needs to be reassessed, okay? So in this patient, I think you continue.
Yeah, these are the initial evaluation that was done for the patients, the investigation, full blood count, electrolyte, urine, creatinine, malaria, urinalysis, a glycosylated hemoglobin, and lipid profile. The urinalysis came out to show glucose of 3+ with a full blood count showing relative neutrophilia.
Okay, so the rest of the results is as shown on the screen. So what do we think the diagnosis is? What do we think the next step should be? No, let them see it very well. Okay, so I think one of the key points we want to highlight with this case is monitoring of treatment. Monitoring of treatment, monitoring of treatment. So I've seen patients a lot that will tell you that they will prescribe this medication in 2020 and they've been using it. Do you check your sugars? No. So how do you know it's working? Well, I take my drugs. Well, that's not enough. You need to know that it's working. And monitoring treatment is important, okay? You want to monitor to assess the response, and you should not assume that just because someone is getting medication or getting treatment, that then that means the treatment must be working. No. It's important to monitor rightly. So we have patients that monitor too much, and then some monitor too little. The amount of monitoring we do should be based on these things I wrote here: intensity of the treatment, risk of hypo, whether there is complications already, whether you recently escalated medication. And the monitoring frequency is as written here as well. So some people can need low monitoring, but some needs quite high frequency of monitoring. But beyond monitoring, it's important to understand, interpret, and act on the data. Okay, and I have a lot of patients that don't do that, even a lot of doctors that don't do that. And what I tell my patients is that it's like you employ a security man to sit outside to be checking for armed robbers, and they see armed robbers coming, then went back to sit down. He look out again, see that the armed robbers are closer to the house, then went back to sit down. So why are you checking? What's the point in checking if you're not going to act on it? And you can see that woman has been getting fasting in the range of 20 millimoles per liter, and then they're still doing the same thing. So that's futile monitoring, so to say. So it's important that we act on it, and then we don't let any monitoring go to waste. So we should do the A1C routinely for our patients at this frequency, usually at 3 to 6 months, and target to be individualized, typically less than 7% for most patients. And if targets are not being met, particularly within up to a 6-month period, you need to escalate care. You need to escalate care. We should not continue what we can see that is not working. And it's important to educate our patients about targets as well, because patients that are well educated, once you've told them the target is not being met, even if you as a doctor don't do the right thing, they'll say, but doctor, this thing is high now, okay? So if targets are not being met, what should we do? These are what we should do. Cross-check the diet, weight control, physical activity, make sure the patient is using the medication and following the treatments as agreed, reassess the drugs you're giving the patient. Is this an appropriate combination? Reassess the type of diabetes. And then, of course, in type 2 diabetes, you should consider whether there is beta cell failure. We do know that more than half of patients with type 2 diabetes will have beta cell failure and begin to require insulin after about 7 years of diagnosis. That's from pool studies, okay? And of course, if targets are not being met within 6 months of care, we need to escalate and let the specialist say. Don't allow patients to fool us that, doctor, don't worry, let me just work on my diet and my exercise. For gross glycemic gaps, what I mean by gross glycemic gaps, I'm talking of A1C that is really above target. So I'm not talking of someone that is getting 7.4 or 7.8, in which, you understand what I mean, Abi? That what you need to get down is not much. But someone's having A1C of 9.2. What dietary change do you want to change that will bring 9.2 to 7? There's nothing you're going to do in that regard. So And we should realize that diet and exercise will never get to ideal. I'm not sure if anybody does ideal, whose diet is ideal, that is perfect, 100% here. No. So don't let patients keep pushing you, because they do that a lot, okay? And by saying that, doctor, let me work on my diet, they do it, they say for like 3 or 4 years until the kidneys are gone, and then we're now running helter-skelter. So that's important. It's important to recognize that even though type 2 diabetes accounts for more than 95% of diabetes, there are still other types of diabetes. There are other types of diabetes, okay? And because diabetes is a very common condition, some of them will be the other types, okay? It's important to also know that about 10% of people that are diagnosed with type 2 diabetes are actually what we call LADA, that's latent autoimmune diabetes of adults. So like a type 1 diabetes, but it's a slow, smoldering kind of type 1 diabetes, such that the beta cell damage and failure takes place over years rather than days to weeks of the classic type 1 or autoimmune type 1 diabetes. We should also be able to recognize hyperglycemic crisis, which was one of the lessons for this case. I'm not sure, it wasn't part of the poll, but do we think that the case we presented is an hyperglycemic crisis or not? Okay, so she had glucose that was quite high. I think it was in the range of 300 or something like that. Okay, but the patient was otherwise largely fine, just mildly dehydrated. So in HHS, which is one of the common hyperglycemic crises, so we have 2 common types of hyperglycemic crisis. We all know that already. So, but when we see patients present with diabetes, presenting with patients with diabetes or patients with hyperglycemia, presenting with acute illness, significant hyperglycemia greater than 250, or acute metabolic derangement, that's talking about maybe creatinine a bit high, urea high, or metabolic acidosis most importantly, you should ask yourself whether you're dealing with an hyperglycemic crisis, and it is often missed. I will tell you that. It is often missed, okay? So we have criteria for HHS as hyperglycemic hyposmolar state, and these are the 3 cardinal things you tend to see there. That's usually a profound degree of dehydration. Patient is usually very dry. Marked hyperglycemia, typically greater than 600. Raised serum osmolarity, which you can calculate using the formula below here. Okay, the other typical things we see in HHS is illness, typically over several days to week. Typically older patients. It's uncommon in young patients. And then metabolic acidosis is usually not prominent. Ketosis or ketonuria is usually not prominent either. Okay, compared to DKA here, in which you usually tend to have a more milder or moderate degree of dysglycemia. Metabolic acidosis is a must in DKA. Acidosis is central to the name of the diagnosis. You tend to see ketonemia, and then typically it's more of an acute illness, typically a younger patient. Typically there's hypovolemia, which is usually less marked than what you see in HHS. Okay, and then more common in patients with type 1 diabetes generally, but in reality, because type 2 diabetes is more than 95%. So most of the DKA we see here is still more in type 2 diabetes. And of course, if you calculate the anion gap, it will be high. So anytime you see a patient with hyperglycemia, blood glucose above 250, you need to ask yourself whether it meets the criteria for a hyperglycemic crisis or not. Of course, there's what we call the euglycemic decay, but I won't want us to go into that at all. So of course, there are other hyperglycemic states, uncomplicated hyperglycemia, or hyperglycemia with other acute illnesses. So someone comes with sepsis, and then there is hyperglycemia. It's not an hyperglycemic crisis itself, okay, but you need to pay special attention to that. So now go back to these patients we discussed as we're rounding up. You can see that the patient is a young patient, 33-year-old, diagnosed 6 years ago. That means he was diagnosed in her late 20s, okay? Failure of oral glucose-lowering agents. There are clinical symptoms, typical diabetes symptoms. The patient was not specifically acutely ill. The examination findings, the patient was not overweight or obese, which are classical or typical things we see in type 2 diabetes. Was only mildly dehydrated. Vital signs were unremarkable. And of course, we have this investigation results, okay? So, given that, do we think the patient has HHS or DKA? Who has any thoughts on that? Do we think the patient has hyperglycemic hyposmolar state or diabetes ketoacidosis? Any thought, any thought, any thought? Neither. So someone says neither. So I agree with that. So the patient does not have either of, the patient does not have an hyperglycemic crisis. Okay, but the patient has just severe hyperglycemia, poorly controlled diabetes, malaria test positive, and no ongoing infection was identified. The corrected sodium, we should know that hyperglycemia can give us what we call pseudo-hyponatremia, okay? Just due to the osmotic changes, pulling some water into the extracellular tissue that would dilute the sodium. So the corrected sodium was not so bad. Okay, and the background diabetes type was thought to be LADA. She fits the profile for latent autoimmune diabetes of adults, and clearly the oral agents were not working. And of course, we did a GAD65 antibody test in a patient, which is available. It typically comes out in about a week or so. which confirms the diagnosis of LADA, that's bladder diabetes. And of course, she was still admitted for inpatient care. Sorry, the result came out after treatment or after this acute admission. Admitted, some rehydration like people picked, blood glucose was managed, and of course she was converted to insulin, and her glycemic control has been excellent since then. Of course, patients are typically happier. Unfortunately, patients that are poorly controlled on inappropriate treatment, typically they tend to starve themselves. I'm not sure whether you've seen such patients. The doctor, even when I eat cucumber, my sugar will go up, and then they'll be frustrated. They tend not to eat, their lives are miserable, but with right treatment, patient is able to go back to a normal diet. Now, when I say normal diet, I don't mean an unhealthy diet, but a normal, balanced, healthy diet that everybody should be able to eat. And usually, of course, they're grateful for it. So I think these are some of the learning points we've picked today. I won't go through them. Thank you very much.
Thank you very much.
Any burning questions? Any questions? Any questions? I'm not sure we asked any during the course of the presentation.
Okay. Thank you very much. In your experience, I don't know whether you've had cases that you would say are in remission. You know, like you have patients, you started them on treatment, and with time, you've downgraded the treatment to the basal level. At what point would you take them off that treatment, or is it treatment for life?
Thank you very much for that question. I think that is a theme that is on many people's mind, actually. So yes, diabetes mellitus can technically be in remission, but the remission, or the so-called remission, is a technical term. It's purely a technical term. So treatment of diabetes mellitus is generally lifelong. Now, the medications are not lifelong, okay? And we know that treatment can continuously be escalated or de-escalated. So we have patients that from onset of treatment, they lose 5 kg, they lose 10 kg, they don't require medication again, and then they continue to be fine. They can be fine for years, okay? We can technically call that remission, okay? But that lifestyle treatment, that physical activity, that dietary changes is still a form of treatment that they continue. And that's why I refer to that remission as a technical term. But yes, that is actually very common. So if you have a patient that weighs maybe 110 kg today now, and the patient has diabetes, maybe fasting in the range of about 154 or 160, A1's around 8 or so. If you start medication now, which is fine, but the patient is able to lose 10 or 15 kg, the person will not require medication again, actually, okay? But we all know the issues with lifestyle modification. Patients find it difficult to sustain, are we? Yes. And of course, unfortunately, again, diabetes is a progressive disorder, and that means that the incompetence of the body in handling glucose and other nutrients is something that continues to evolve and generally gets worse over the years. Beta cells apoptosis continues to worsen over the years. So even if that graph is common, basically. So the person actually gets better, stop requiring medications, then several years later. But the key thing is to keep monitoring. So yes, we do stop patients' medication sometimes, particularly if someone that was diagnosed early and was able to do a lot of lifestyle interventions to mop up a lot of the issues. Thank you very much for the question, sir.
Thank you very much for your presentation. Please, I would like to ask about what is the current, in current clinical practice, what is the place of Dionyl in the oral management of diabetes? Thank you.
So thank you for the question. That's glibenclamide still has a role in the management of diabetes. As much as possible, the Western world is shying away from use of sulfonylureas, and that's totally appropriate because of the issues. A lot of us prefer glimepiride to glibenclamide, okay, but they're both sulfonylureas. Okay, but it still has a lot of role in developing countries like ours. It's cost efficacious. Don't let me say cost efficacious. It's cheap. It's accessible. So those are the main points. Okay, but metformin will give you a better bargain. the other agents, SGLT2 inhibitors, DP4 inhibitors. So all of those guys are things that we should prioritize instead of softener areas. But of course, cost often pushes us back to the softener areas, and their role in the management of diabetes in this part of the world cannot be denied, and it's going to remain so for the next several years, really. So it still has a very strong role. Thank you very much.
Okay, thanks again. For type 2 diabetes who have a risk factor of diabetes, either grade 3 or 4, with poor glycemic control, I wanted to know your experience with use of GLP-1 agents, either the injectables, Ozempic, or the tablets, Ribelsus, if you have any experience to share. Thank you.
Sorry, I didn't get the question very well. For people with diabetes that have what?
Glycemic control with obesity, either grade 3 or grade 4.
Grade 4 what?
Obesity.
Oh, obesity. Thank you very much. So the truth is that the GLP-1 agonists they are very good medications. They're excellent medications. So I've had experience with them, and it helps with weight loss. Now, the amount of weight loss the amount of glycemic control you get, and the amount of weight loss you attain is quite variable within individuals. But yes, I've seen some quite, I won't say dramatic, but quite remarkable weight loss with it. Unfortunately, the weight loss is only sustained as long as the person can sustain using the medications. And unfortunately, many people are unable to sustain the medication. So it does well with both of that. And additionally, we know that it has benefits in reducing cardiovascular risk, particularly risk of stroke and MI and all of that. So yes, it works very well in that regard. And there are some weekly ones now that just requires to be used once a week, but the price tag is still very hefty for now, unfortunately. Hopefully, over the next few years, we might be having some biosimilars in that regard that might be more affordable to the regular Nigerian. Thank you very much.
Okay. Thank you very much. Once again, I'll be referring to the multidisciplinary team. You know, since you've mentioned that there was a lot of, a lot of improvements with patients who had undergone, let's say, weight reduction, management of obesity or something like that, and also nutrition or dietary changes. Now, how do you as a member of the multidisciplinary team, you know, because it's easy to see that patients are not going to adhere to these things. They're not going to adhere to the advice to, you know, to work out or to watch their weight or manage their diet and all that. So how do you ensure as a member of the multidisciplinary team to get other key players involved? Definitely the exercise expert, probably an exercise physiologist or a physiotherapist, is meant to be a member of the team managing a patient with diabetes, the nutritionist and all. So how do you get them to actually be very involved in this management? I actually came across a study that was looking at the role of these, you know, different combinations in management of patients with diabetes type 2 specifically, and reported reversal of that, you know, type 2 diabetes. And that was a combination of, I saw like 3 different studies: bariatric surgery, physical activity and exercise, and then nutrition. And I saw another one basically talking about just physical activity, nutrition, and medications. So that quite fascinated me, and I wanted to throw the question: how do you get other members of the team involved? Thank you.
Like you rightly said, multidisciplinary care is the name of the game. Now, in terms of getting patients to do regular physical activity, most people don't actually require a personal trainer or anything to do regular physical activity. It's just human nature to start well and then decline. So just general encouragement in clinic and things like that. Now, there are specific patients that require support from the physical therapy team. And those patients are very common. So you can have patients who have osteoarthritis. They'll tell you that I cannot walk if I try to walk, and then they require specific exercise. So some people have musculoskeletal limitations, and then people with gross obesity will require that as well. Some places have gym, spa, or other memberships as things to be an incentive for patients to do. Okay, but I don't think anything particularly beats reminding the patients each and every time to follow up on other components of the treatment, particularly the lifestyle part. And usually I tell patients that that's the most difficult part to do in a sustained way. But again, like you rightly said, multidisciplinary care is the way to go with the dietitians, people that require a personal trainer or specific requirements for the exercise, which is common again. People that are very obese. I have a lot of people who have severe arthritis and then they have pain in the back when they do this, and those have to see a physiotherapist to guide them in what they can do. Some is swimming or cycling or some other specific. So we should identify the kind of patients, and those are the patients that really, really struggle to get enough physical activity. So thank you for that question, and it highlights the role of the MDT.
Thank you, Chief, for that wonderful presentation. Are we tired? Our brains are tired, right? I can see smoke coming up from our heads. Now imagine you have to do this every morning. Okay, so we are fast behind time. On the agenda, what we have is the lunch break, but we will not be breaking. We'll be having lunch where we are seated without much fanfare. And we'll be moving on with the next item, which is a presentation titled Tackling Cerebrovascular Risk in Type 2 Diabetic Patients. And this will be taken by Anosike Chika-Okoli from Boehringer Pharmaceuticals. Please make her welcome. I know we are tired, but please make her welcome.
Good afternoon, everyone. I want to say, first of all, thank you to Dr. Wofisoye for that in-depth discussion on diabetes management and complications. So I will just write on that. My name is Anosike Chikodili, but you can just call me Chika. I'm a medical representative for Boehringer Ingelheim. I know most of us here are already familiar with the company, but for the benefit of those who are not, Boehringer Ingelheim is a German pharmaceutical company founded in 1885, family owned up till date. For the purpose of this presentation, we are going to be looking at Jardiance, empagliflozin, the topic, tackling cardiovascular risk in type 2 diabetic patients with emphasis on EMPA-REG outcome trial. Before we go further, I'm just going to describe a patient profile who represents the kind of patient we see daily in our clinical practice. So I present to you Mary, who is a 57-year-old woman diagnosed with type 2 diabetes about 5 years ago, has coronary artery disease 3 months ago, right? Her mother had type 2 diabetes, died of MI, and then she used to smoke but quit 17 years ago. What are her current vitals? Height 5 feet 7 inches, weight 86, BMI 30, systolic blood pressure 35, diastolic 85. And so if I ask at this moment, how are you currently addressing patients like Mary and their risk factors for cardiovascular death? You remember all the guidelines that Dr. Wofisoye has laid out for us. So I'm just going to add to that. So I don't want us to answer these questions. I just want us to have at the back of our mind. I believe that by the end of this presentation, this question will be answered. Globally, we have the prevalence of diabetes really on the increase. So we have 450 million people currently living with diabetes. And this number is expected to increase to 642 million by 2040. This is just for diabetes mellitus. And then for patients who have diabetes, they have a life reduction expectancy by 6 years. And it more than doubles when there's a history of MI. So a patient who has type 2 DM, history of MI and stroke, has a reduced life expectancy of 15 years. That is a whole lot number of years to be taken out of somebody's years on earth, right? On a daily basis, the nephron filters approximately 180 grams of glucose per day. The sodium glucose cotransporter 2 inhibitors, going forward I am going to refer to as SGLT2 inhibitor, reduce glucose reabsorption in the proximal tubule, thus leading to urinary glucose excretion and osmotic diuresis. What's the mechanism of action for empagliflozin, Jardiance? Prior to the initiation of Jardiance, at the proximal tubule, we have the SGLT2 and the SGLT1. The SGLT2 is responsible for reabsorption of 90% of glucose back into the bloodstream, and SGLT1 takes 10%. So after the initiation of Jardiance, what you have there is the 90% that is supposed to be taken back by the SGLT2 is excreted. So you have increased urinary glucose excretion. And so what does Jardiance look like? Jardiance, which is empagliflozin, comes as a tablet, 10 milligrams and 25 milligrams, taken once a day, with or without food anytime in the day. Absorption, peak levels about 1.5 hours. You have half-life of 10 to 19 hours. Steady states reached by approximately day 5. Metabolites to no active metabolites and is excreted via the kidneys, urine and feces. This just states that with Jardiance, you don't have to be worried about other medications that this patient is going to be on. So you can use Jardiance comfortably with other anti-diabetic agents, antihypertensive, and antiplatelets as well. And so we go straight to what the efficacy of Jardiance is. Jardiance can actually be used as monotherapy or in combination. But for this study here was head-to-head trial with sitagliptin at week 24. You see that within the baseline of HbA1c of about 7.9, 7.8, Jardiance has comparable HbA1c reduction with sitagliptin. But fast forward, HbA1c greater or equal to 8.5%, you start to see Jardiance having a greater reduction in HbA1c than sitagliptin. And then you get to as high as over 11, right? Jardiance 25 milligrams did the magic, 3.7% reduction in HbA1c, this still at week 24. Same as monotherapy, Jardiance was compared head-to-head to Rimepride, 1 to 4 milligrams. This study spanned for over 4 years. And then here you see that Jardiance is sustained. Oh, okay. You have the reduction sustained for over 4 years. So it has better reduction compared to the sulfonylurea Rimepride. Also offers sustained body weight reduction in the 4 years. So in addition to reducing HbA1c, Jardiance also helps to reduce systolic blood pressure. Now, it's good to note here that this is for people who have uncontrolled blood pressure. For those who have controlled blood pressure, there is no negative impact. So you have for patients who are, for example, hypertensive diabetics, right? So Jardiance reduces HbA1c significantly, also reduces systolic blood pressure. Like Dr. Wofse rightly mentioned, type 2 diabetes is a major and independent risk factor for both microvascular and macrovascular complications. And it's general knowledge that tight glycemic controls will confer benefits for the microvascular complications like the retinopathy, the neuropathy. But you have the macrovascular complications, the lack of strokes, the lack of heart failure, left unattended to. So it's really important that when managing diabetic patients, we go beyond just reducing the numbers. These days, it's really gone beyond reducing numbers. What else can this medication do aside reducing numbers? Because addressing the burden of cardiovascular events, including the death, is at the core of diabetes care. Having in mind that over 50% of patients who have diabetes die of cardiovascular disease. Let's put this in perspective. So we have 10 patients, right, having diabetes. Naturally, about 5 or 6 of them would just die of cardiovascular disease. So it's good to have this percentage at the back of our mind when handling diabetic cases, so that we know that it is really beyond just reducing their numbers. It's also a holistic aspect where we consider the cardiovascular risk of this patient. And so we go straight to the study that we wanted to discuss today, EMPA-REG outcome trial. This study was announced in September 2015. Empagliflozin cardiovascular outcome and mortality in type 2 diabetes. This study was carried out in 42 countries, spanned over 590 sites, Africa included. So the patients were randomized into 3 arms. We have the placebo arm, Jardiance 10 milligram, Jardiance 25 milligram. It's good to know that for patients who were on the placebo arm were on standard best of care. So they were on best standard of care. So for those who were on Jardiance, that's empagliflozin 10 milligrams, 25, it was added on top of best standard of care. So for key inclusion criteria, we have adults with type 2 diabetes and established cardiovascular disease. So we have patients with coronary artery disease, history of stroke, peripheral artery disease, and heart failure included in this study. Now remember, I said those who were on placebo were on best standard of care. So they were on metformin, insulin, if they needed it. You were on statins, the RAS blockers, beta blockers, depending on the patient that we're looking at. So they were on best standard of care. So what did the result from this study say? The primary composite endpoint, that's 3 PMAs, major adverse cardiovascular events, entailing cardiovascular death, non-fatal stroke, and non-fatal MI. We have 14% relative risk reduction in this patient, for those who were on Jardiance arms. Jardiance reduced incidence of cardiovascular death by 38%. It's good to note that this started early. So within 0 to 6 months, you can see the graphs separating very early. These patients started getting the benefit. Remember that over 50% of patients who have type 2 diabetes will eventually end up with a cardiovascular disease. And here this study shows Jardiance giving 38% relative risk reduction for cardiovascular death. Then the incidences for hospitalization due to heart failure, you see Jardiance in this study offering 35% relative risk reduction. Remember, it starts early. It starts early. So it's good to initiate this medication early in your type 2 diabetic patients to get this benefits. Jardiance reduces incidence of all-cause mortality by 32%. Like I said, I keep emphasizing on the early start of Jardiance in patients. In patients with diabetes and established heart failure, the risk of death increases by 60 to 80%. This is a very high percentage. People with diabetes have 2 to 3-fold higher risk of developing heart failure. And then you hear in this study, Jardiance confers 35% relative risk reduction for hospitalization for heart failure. And I know that you would agree with me that for patients who are hospitalized for heart failure, it is not easy on both patients and the physician managing. So in a situation where you have a medication that keeps these people out of the hospital more, I'm sure it's something you would be interested in, and it starts early. Jardiance, in addition to standard of care, reduce the risk of heart failure outcomes in adults with type 2 DM and at high severe risk, ranging from HHF or CV death to investigator-reported serious heart failure. You will see that there are significant reductions across board. Mortality is more frequent in type 2 diabetic patients with kidney disease than in those without. It is common knowledge about 40 to 60% of patients who have type 2 diabetes will eventually come down with some form of kidney disease. Now, this is a disease progression. And so, patients who have diabetes and no kidney disease, 4.1% mortality rate, as high as 47% when there's albuminuria and impaired GFR on top of type 2 diabetes. And from this EMPEROR outcome trial, we see Jardiance conferring 39% relative risk reduction for incident or worsening nephropathy. Jardiance, in addition to standard of care, significantly reduced the rates of clinically relevant renal events in adults with type 2 DM at high severe risk, ranging from progression to macroalbuminuria, doubling of serum creatinine, to initiation of kidney replacement therapy as high as 55% relative risk reduction. Jardiance also prevented EGFR decline with, as compared with placebo, like we can see here. The placebo just plateaued down. But those who were on Jardiance, 10 milligrams, 25 milligrams, you can see that there's an initial dip, but this improves over time. In EMPEROR outcome trial, Jardiance demonstrated safety and tolerability. So the drug is well tolerated. Yes, there is most common side effect, I would say, the UTIs and dehydration, but this also can be handled if the patient takes fluid and proper hygiene. For the UTIs, is more common in females. Of course, you would understand why, and mostly the elderly. So in summary, what have I been saying about the EMPEROR outcome trial and cardiovascular risk? Jardiance, in addition to standard of care, significantly reduced cardiovascular risk and improved the overall survival rate in adults with type 2 DM at high cardiovascular risk. Well, remember Mary, the patient who we had profiled at the beginning. So imagine Mary having this 38% relative in cardiovascular death, 32% in all-cause mortality, and 35% in heart failure. And so guidelines began to change after the study had happened. You see the ESC guidelines adjusting and including Jardiance in the guidelines. And it says you should start early. I don't know if we see that. The use of an SGLT2 should be considered early in course of disease. And the guideline collaboration with EAS, the ESC guidelines states that for treatment-naive patients, newly diagnosed type 2 diabetic patients, if there is presence of atherosclerotic cardiovascular disease or high or very high CV risk, start an SGLT2 inhibitor or GLP-1 monotherapy first line. And then if HbA1c is still above target, add metformin. But if none of these risk factors are present, metformin monotherapy first line still stands. And so if I ask at this point, what will you do to reduce the risk of cardiovascular death in adult patients like Mary with type 2 diabetes and established cardiovascular disease whom you see every day? I'm sure you have your answer. I'm sure we know how to manage this patient. It's beyond just reducing numbers. It's also what else can a medication do, and that is what Jardiance can offer your patients. So in conclusion, Jardiance is, like I said at the beginning, 10 milligrams, 25 milligrams tablets given once a day, is indicated in both type 2 diabetes and heart failure. So for patients who you need a tight glycemic control for HbA1c and the EGFR, there's sufficient EGFR of over 60. For those patients alone, you can go up to 25 milligrams. Patients with EGFR between 30 and 60, you maintain on 10 milligrams. Now, this is for type 2 diabetes. For heart failure, Jardiance is indicated regardless of ejection fraction. You can use as low as EGFR of 20. So, but remember, for type 2 diabetes, EGFR contraindicated below 30. If the EGFR is over 60, you can titrate up to 25 milligrams. And it's good to note that you can use Jardiance comfortably with the other anti-diabetic agent. But caution is advised, apply caution when using with an SU or insulin to minimize the risk of hypoglycemia. So this is what Jardiance looks like. It comes as a pack of 30 tablets, a card of 10 tablets, and there are 3 cards in each pack. Looks beautiful, I know, right? Thank you so much for your attention.
Thank you very much for that. Before we have the next presentation by Novartis, I just want us to know that we'll be having the BLS session immediately after the Novartis presentation, so that you don't go. Please stick around. It's going to be both hands-on and then the teaching. So I'll be calling up Novartis for their presentation on early treatment, intensification with Gavosmet, and the novel management of dyslipidemia. Please here. Okay. Thank you.
All right. All right. Good afternoon, everyone present. I don't want to take much of our time. I know we're all tired, but I believe with the little I'm going to share with us today is still going to add more to our practice. Yes, I would want to thank the speakers that spoke before, for sure, the other medical rep. For me, what I want to look at this point with also managing our type 2 diabetic patients, the fact that we want to start them early enough with early treatment intensification is a way to go to avert complications that will arise as a result of poor management. And one of the striking things I want to say is that clinical problem with the clinical inertia is a deep fall in getting this patient to go. And it implies that there will be a treatment failure, beta cell progression deteriorates more faster, and complications are bound. That's when we have a bad practice where we don't have good legacy effect for this patient in early combination therapy, managing them to avert these complications. So it now throws this question to us. If you agree with me that combination therapy as an early strategy in managing this patient, will it be of benefit or even of more benefit to this patient compared to when they were sequential additive therapy, as the case may be? Having said this, you agree with me that before diagnosis, the treatment of diabetes has started long before now, that even at 0, when these patients are diagnosed, 50% of the beta cells is gone, and the remaining 50% deteriorates over time, as we can see. So hence, the need for early treatment intensification is paramount in getting these patients to go. So, having said this, the oral treatment
oral treatment criteria, we know, do not really address majority of the islet cell dysfunction or the parameters that cause type 2 diabetes, which are usually insulin resistance and the pancreatic islet cell dysfunctions. Here we have many medications who has fallen into this class to help manage these patients properly, but then we have some defaults. And one of the things we know that metformin remains a good therapy in managing this patient. And aside that, we have other oral agents like sulfonylureas and glanites who actually do more on insufficient insulin secretions from the beta cells. But what happens to the alpha cells and the progressive decline of the beta cells? This remains unattended to. Permit me at this point to say that with vidagliptin, which is a DP4 enzyme inhibitor called dipeptidase 4 enzyme inhibitor, it addresses this core 3 major issues and gets this patient to go early enough, because it has in 2 faceted ways, where in the fact that if there is hyperglycemic state, it stimulates the beta cells to produce insulin and suppresses the alpha cells at the same time. At hypo state, it rather suppresses the beta cells and stimulates the alpha cells at the same time. And these are all done in a glucose-dependent manner. That way, you avert complications that arise as a result of hypoglycemia. So in line with this, you agree with me that conventional treatment approach has been our major care, where we want to use diet and exercise for most of these patients before we even think of placing them on oral therapy. But you can see from this graph here, it has not really addressed majority, especially bringing them down below 7, which is the treatment guideline goals for majority of the patients to get to go. And that in that format means that there's a bad legacy effect, because a good legacy effect is where you want to intensify treatment early enough to avert complications that will arise in these patients. And if you agree with me on this, that means combination therapy early enough for this patient, according to Verify, has shown there's going to be a reduction in macrovascular complication in micro and death related. And the figure subsequently shows that with the macro, we have a 39% reduction. We have a 29% reduction with macrovascular and 29% reduction death related, meaning that this patient will be below 6.5% of glycemic control and within the follow-up at that period. At this juncture, I would want to allay our fears, because most of the times our conventional practice has been very paramount with us. But then what it means is that if you place this patient early enough on combination therapy at the early stage, because some of them have lived in denial, but then when they present to us, is a need for us to place them early enough. So Verify is an acronym meaning that vidagliptin efficacy in combination with metformin for early treatment of type 2 diabetes. This was a study carried out for over 5 years. So the earlier, the better we catch this patient early enough, the better for us in managing them appropriately. You agree with me that monotherapy was what was used here, and the patient value we used here was between an HbA1c of 6.5 to 7.5 as an entry target. And it spanned the course of 5 years. It's a 5-year study that has a multi-center randomized and double-blind, meaning that both the physicians and even the patient involved do not know what they are taking. So, will you allow me at this point to say there could be a new approach in managing this patient? If that's the case, then community to say that even you want to start this patient on monotherapy and dietly, it will not give the desired result. But the new approach is that you can start this patient also on those and with a combination therapy early enough. That gives the significant result you want to attain in this patient. So Verify has actually been, like I said earlier, is a randomized double-blind trial which was carried out in over 2,000 patients in over 254 centers on over 36 countries, including Africa. So this study has actually proven that with these, we can allay our fears, because one of the primary endpoints they look at is time with combination therapy early enough in this patient. And you agree with me from the demograph we have here that there was a screening period for this patient at the point of entry where they were on metformin to the maximum dose for 3 weeks before they were randomized equally for those on vidagliptin, metformin as galvosmet at the early stage and those on placebo and metformin. Failure in this patient is also very important to note, because they wanted to know when to uptitrate this patient and what the benefit will look like at the end of the day. Now, the primary endpoint and secondary endpoints are time to treatment failure. But as we can see with the study, most of the patients who are on galvosmet early enough have a better control with time to treatment failure well reduced compared to those on placebo and metformin who were uptitrated to vidagliptin and metformin at the end of the day. So study time for 5 years is a robust study for us, if you agree with me, and for newly diagnosed, which has not happened. So it allays our fears as we want to start with diet for this patient before monotherapy. You can as well start them on diet, exercise, and combination therapy early enough. So key finding applications states that with this patient, with this study, you can agree with me that we have over 75% of this patient who will reverse back to pro-diabetic state, meaning that out of 4 patients, 3 of them will achieve the desired HbA1c result. At this juncture, you also note that there are over 40% of this patient who will have tight glycemic control for the course of the study for 5 years. It's very paramount compared to monotherapy. And those also had shown that they have a better and enjoyed a good glycemic control of over 56% of this patient versus monotherapy, who has 38%. Yes, you agree with me that even as much as we have these studies, that then we also have no increased risks of hypoglycemia. Now, at this juncture, I also want to state that there are even cardiovascular benefits found with the use of galvosmet, as the case may be, according to McLean et al., where it said that even the parameter of 1 were not achieved with this patient, and for that reason, it's safe that it will not progress any patient on cardiovascular risk or even impose any for this class of patients. At the same time, there were baselines of weight gain neutrality in this class of patients, even with the use of metformin and vidagliptin, as the case may be. Now, one striking thing I want to tell us here that because of the way galvos acts, which is because of the way vidagliptin acts in galvosmet, it actually delays the deterioration of the beta cells. Rather, it improves it over time, according to what we see here, because there's a whopping 19% differences for patients who are on early combination compared to those on initial monotherapy in getting their beta cells back to function, as the case may be. So key findings with Verify has stated that there are 49% reduction to initial time to treatment failure compared to monotherapy strategy, and there's also a 26% reduction to second treatment failure as a result of additive strategy added on this patient. It confirms that a robust part of this patient gets to good glycemic control with weight neutrality, and it converts around a larger population of this patient, even both the elderly, as the case may be, well tolerated according to what the study has given us. And the clinical evidence is that it improves long-term glycemic control durability compared to metformin monotherapy. So, the durability of Verify has stated that with this all we stated that we'll be able to get this patient to go. Permit me at this point to say that even in the guidelines of 2021, it's already included that combination therapy early enough is recommended in managing this patient. Now, there's a key outpoint yellow graph that says that this result has been generalized to all other agents other than vidagliptin. It's important to note that vidagliptin, which is galvosmet, has been the one which the guideline has indicated that early combination with metformin will give the desired result. Permit me also to state that even with this early combination, we can also fit galvos and galvosmet in different categories of the patient that presents on our clinic. For our newly diagnosed patient, if you start them on galvosmet early enough, you will get a whopping 3.2% reduction in HbA1c, according to Bossi et al. You can also use it on uncontrolled patients with metformin when you switch their metformin to galvosmet. And those on uncontrolled metformin plus sulfonylureas, when you switch their metformin to galvosmet and reduce the dose of the sulfonylureas, it has shown that a whopping 1.1% reduction is achieved in this class of patients with low incidence of hypoglycemia and weight gain. Uncontrolled on insulin and insulin metformin has actually shown that if you switch their metformin to galvosmet, you get a 0.8% reduction in HbA1c and less hypoglycemic weight as well. So even for end-stage renal disease patient, galvos plays a role because you get up to 0.92% reduction in HbA1c and saving costs for this class of patient. The drug presents itself in this format, so we have it as vidagliptin 50 mg, or we also have it as galvosmet in a pack of 6 cards inside of per 10 tablets for a monotherapy for this class of patient. Thank you for your time.
Good afternoon, professors, consultants, senior colleagues, and colleagues. May I have my slides up, please? My name is Dr. Benson Uzoma, medical advisor for the cardiometabolic franchise Novartis. And today, I would like to tell us a story. Even though, because of time, I will tell this story very fast. We clearly understand that cardiovascular disease is the number one cause of mortality worldwide. And we have a lot more mortalities from cardiovascular disease versus cancer, respiratory disease, and diabetes put together. Data from the WHO 2018 country profile shows that 11% of mortalities are as a result of cardiovascular disease in Nigeria. Now, sorry. Dr. Oji et al. Showed that here in Abuja, we see comorbidities identified among patients who are newly diagnosed for hypertension, includes obesity, followed closely by high total cholesterol. Professor Carrier et al. Also established that in sub-Saharan Africa, we have a preponderance of about 38% of patients with dyslipidemia, out of which 49% of them have ischemic heart disease and 26% have cerebrovascular accidents. Professor Eguejofor and Odenibo also showed that in Nigeria, about 60% of apparently healthy individuals have dyslipidemia, while about 89% of diabetic patients have dyslipidemia. This is just to paint a picture of what the burden looks like. It's also important to note that before now, we have always sent familial hypercholesterolemia to the background. But I am sure that many of us here, empirically, in the absence of genetic testing, have been able to identify some patients who you suspect have familial hypercholesterolemia. Now, cardiovascular disease could be divided into two: the atherosclerotic types and the non-atherosclerotic types. Today, I will be focusing on the atherosclerotic cardiovascular disease. And these are the contributions in terms of the numbers from ischemic heart disease, ischemic stroke, and peripheral artery disease. In fact, within 1 minute, you have 34 people dying from atherosclerosis worldwide. We've seen that there are modifiable and non-modifiable risk factors for the development of atherosclerotic cardiovascular disease. And thankfully, we've said a lot about hypertension and diabetes already. However, I want to talk about hypercholesterolemia, which is one of the very neglected risk factors for cardiovascular disease in our environment. We don't really pay a lot of attention to it, but we can see the damage that it causes. Now, if you go back to the etiopathogenesis, we see that prolonged exposure to elevated low-density lipoprotein leads to accumulation of plaques behind the intima of the blood vessels. With prolonged exposure and increase in the size of these plaques, the plaques are bound to rupture. And when they rupture, this patient can throw an embolus. And then if the blood vessel taking blood to the heart is blocked, you have a myocardial infarction. If that takes blood to the brain is affected, you have an ischemic stroke. Very important to note, not common knowledge, that most of a person's acquired burden of ApoB containing lipoproteins occur in childhood and in adolescence. So you can see that graph showing you that from the age of 2 to about 18, you have your ApoB lipoprotein levels going up. We need to start that early to begin to watch this occurrence. Now, there is a cumulative low-density lipoprotein exposure threshold beyond which an individual is at risk of having a cardiovascular event. For example, this study by Ferenc et al. Showed that if a patient has a lifelong exposure of LDLC at 80 milligrams per deciliter, the person has a 4% chance of developing a cardiovascular event at the age of 100. However, if he or she has a lifelong exposure of LDLC of 125 milligrams per deciliter, then at about 64 years old, that person already has a 4% chance of developing a cardiovascular event. What's more, if the LDLC level is about 250 milligrams per deciliter, then you can see that at about 30 years of age, this patient has a 4% chance of developing a myocardial infarction. Now, what is the benefit of helping our patients reduce their LDLC levels? You can see from this chart that if we are able to support this patient to reduce her levels from 125 milligrams per deciliter to 80 milligrams per deciliter, then you would have effectively reduced that 4% chance of having a cardiovascular event from the age of, 40 to, from the age of 65 to the age of 100. So if you can work together with your patient to reduce their LDLC levels, then you can help them reduce the propensity of having a cardiovascular event. Now, in general terms, about a 1 millimole reduction in LDLC leads to a 20% reduction in cardiovascular events. So you can't beat that. Now, in our practice, what we've noticed is that we don't risk stratify our patients. When a patient walks in as a cardiovascular patient, it's important to have a baseline risk stratification. So if you look at the WHO cardiovascular risk laboratory-based chart, you would see that there are certain parameters looked at, male or female, diabetic, non-diabetic. Now look at the age of the patient, systolic blood pressure, and if the patient smokes or not. Now, if you use this chart, you will be able to arrive at the risk of this patient, and then you will be able to classify based on the EAS guideline, whether this patient is low, moderate, high, or very high risk. Now, let us look at the patients who are high or very high risk patients. These patients, the goal is for you to bring down their LDLC levels to as low as 1.8 millimole per liter and a equal to or greater than 50% reduction from baseline. And then 1.4 millimole per liter if the patient is very high risk. What we have found out is that we're just placing patients on statins. We don't even know their risk, and we don't even know where we want to go to. It's important to know the risk of the patient, and then we're able to know what dosage of statin this patient needs to be able to get to where we want to get to. So what are the unmet needs? First is to establish that statins are the bedrock of therapy for dyslipidemia or elevated LDLC. Da Vinci study showed us that with respect to the 2016 EAC guideline for LDLC reduction, only about 54% of patients were able to attain their goals. Now, when the goals now got reduced by the 2019 guideline, only half of the 54% were able to attain their goals. So it shows that a lot of our patients are not appropriately managed. The PALM registry showed that patients who were within the bracket of primary prevention, those who have not had a cardiovascular event before, only 36% of them are appropriately treated on statins. Why those who have had previous cardiovascular events, of course, they are afraid to have a subsequent one. So only 47% of them are actually appropriately treated. The reason is that we are placing these patients on statins, but we are not even looking at their risk and increasing or titrating in an upward manner to be able to get them to their target goals. And then this study in Germany also showed that more than 80% of patients who are on statins are not getting to their target goals. In other words, they still have the propensity to have the vascular event, despite the fact that you have placed them on statins. Now, for patients who are on primary prevention, study shows that by 15 months, many of them drop off their statins. And for those who are for secondary prevention, at about 21 months, they drop off their statins for several reasons. They experience side effects, the myocardial pain, the muscle pains, the increase in their creatinine kinase. Some of them don't even know the reason why the doctor placed them on the statins. Why should I be taking these drugs? Especially for those who are primary prevention. They have no symptoms. They've not had an attack before. So why should I be on this medication? And they drop off. And then sometimes for some people, it is cost. Now, there are newer medications, including the monoclonal antibodies against a particular protein called PCSK9, which I will explain in detail. But we have seen that because of the frequency of the dosing of this medication, every 2 weeks, in addition to the statin, patients are dropping off and not getting to target goal. What can we do to address this challenge? Now, let's go back to the pathology or the physiology of management of LDLC in the body. So you have the LDLC particle, right, taken into the bloodstream by this LDLC receptor located on the surface of the liver. Now, this LDLC receptor takes the LDLC particle into the hepatocyte where the LDLC particle is broken down, and then the receptor is cycled back to the surface of the liver. However, the liver produces a substance or a protein called PCSK9, proprotein convertase subtyrosine type 9. It's produced in the liver to regulate the number of LDLC particles in the bloodstream. Now, what does PCSK9 do? When PCSK9 binds to the LDLC receptor, it allows the LDLC particle to also bind. So you have a complex of the LDLC particle and PCSK9 bound to the LDLC receptor. When it gets into the hepatocyte, because of PCSK9, both the LDLC particle and the LDLC receptor are completely broken down. So the LDLC receptor is not recycled back to the surface of the liver. Now, because of that, we have a reduction in the LDLC receptors available. So we have more number of LDLC particles in the bloodstream, which is what we don't want. What have we done about this? We developed inclisiran, a double-stranded small interfering RNA that binds specifically to the liver and affects the production of PCSK9, so that when PCSK9 is not produced, then we have more receptors recycling back to the surface of the liver to bring in more LDLC particles. Hence, we're able to mop up the excess of LDLC particles. And this is what the mechanism of action looks like. When inclisiran gets into the system, right, because of the acidic nature of this claritin-coated vesicle, the complex of inclisiran and the receptors is broken down. So you have free circulating inclisiran inside the hepatocyte. Now, because it is double-stranded, it meets with the RNA-induced silencing complex. This RNA-induced silencing complex is the body's natural mechanism of preventing production of proteins that are not wanted, or proteins that have been produced to an extent where we don't want more of those proteins. So this risk complex guides the inclisiran molecule that now divides into a passenger strand and a guide strand. The guide strand is the active inclisiran molecule. Now, what inclisiran is going to do is that the risk complex will direct inclisiran to locate the mRNA that codes for the production of PCSK9. Remember, PCSK9 is a bad guy. We don't want him here. So, inclisiran locates the mRNA responsible for producing. So, that mRNA would have undergone translation to produce an active PCSK9 molecule. Now, the risk complex will guide inclisiran to locate that PCSK9 mRNA. Once it locates it, the risk complex will cleave the mRNA encoding for PCSK9. Hence, PCSK9 would not be produced. And if PCSK9 is not produced, then we have our LDLC receptors going back to the surface of the liver to bring in more LDLC particles. I'm sure this is clear. All right. So, the 2021 ESC guideline has shown that inclisiran is a small interfering RNA and has been proven to help reduce LDLC levels to 50 to 55% on top of or without the use of statins. So, now, these are the studies, because of time, these are the studies that have shown the efficacy and safety of the use of inclisiran in patients who are on maximum tolerable statins but are not getting to your target goals. So we have Orion 9, Orion 10, and Orion 11. Now, the inclusion criteria were, as you can see on the screen, and these were the characteristics of the patients that we enrolled. Take note that Orion 11 included African patients who also had what we call ASCVD equivalent, including diabetes type 2. Now, the dosing was this. You give inclisiran subcutaneous medication, 284 milligram subcutaneous on day 1. After 90 days, you give the loading dose. And then after that, you give the medication every 6 months. Remember, these patients are already on baseline statins. What were the results? We saw a marked 47 to 49% reduction in LDLC levels in these patients. And then, with respect to our goal of helping these patients attain a 50% or more reduction in their LDLC, we saw that in Orion 9, we had 38% of these patients, 72% and 57% of these patients attaining that more than 50% reduction in their LDLC levels. In general, we had 74% of patients attaining their goals. Because you already have a goal you want to take the patient to, you are now, guided as to what you want to do. We saw 74% of patients versus what we saw initially where we had only about 39% attaining their goals. Now, the next question the cardiologist will ask me is this. Beyond LDLC, we have other ApoB-containing lipoproteins that are responsible or atherogenic. Now, we also saw that beyond LDLC, PCSK9, total cholesterol, non-HDL that includes your small and very low density lipoproteins, your ApoB lipoproteins, and LP-little-a were all reduced across board, while HDL cholesterol was increased, which is what we want to see typically. And now this picture shows us not just that we have helped a patient attain a reduction in LDLC, we see a sustained reduction in their LDLC levels, which is what you want to attain to prevent a reoccurrence of a myocardial infarction or a primary event. Now, with respect to safety, one of the red flags you'll notice is an injection site reaction. Because this medication is subcutaneous, many of the patients had injection site reactions, which were transient and had no other effect. And then I've talked about the dosing. No, so for these patients, they are patients already who have elevated LDL-C. You have placed them on statins. Some of them are having side effects to the statins. Or you are not comfortable with the reduction at all. They are not getting to go. You are afraid that this patient is going to have a repeat event. What you do is to add inclisiran as an add-on to what the patient is already taking. Some of your patients, about 10% of patients we had in our studies, could not take statins at all because they couldn't tolerate the lowest dose. They still had that 50% reduction in LDL-C, even without the statin. But majority of the patients, which is what we preach, 90% of them were on statins, and they were able to attain this reduction. Now, let me lastly mention that inclisiran has been launched in Ghana and is commercially available in Ghana. However, in markets where we don't have our innovative medications, you know we are the innovators, right? So, where we don't have these innovative medications, we have a managed access program where we can help you bring the medication into the country free of charge for the patient. As long as the patient meets the criteria, the patient only pays for the flight fee. So with this, we're able to support you to help our patients attain appropriate LDL-C levels and reduce the risk of having cardiovascular events. Thank you.
All right, thank you very much, Novartis. That was quite comprehensive. Please, if you have more questions, you can meet them. I want to believe the last 5 hours and 30 minutes have been well spent. Do you agree with me? Okay, can we just stand up and stretch in 30 seconds? So nobody says they formed a clot sitting at ACS. Just stretch in less than 30 seconds. Move those limbs. I think you feel better right now. Okay, so let's just welcome Dr. Olalekon to take us with the basic like support. Can we put our hands together for him? Please, you can have your seat, sorry. Let's make welcome Dr. Franca. So
I have Dr. Franca with me because as we get to know that both basic life support and advanced cardiac life support is not something that you can do alone. It involves as many people as you can get. It's a team effort. It's not a one-man show. And why is this important? It's important because it could happen anywhere, outside the hospital, in the hospital. It could happen as we are sitting now, and it is good for everybody to know what to do, appropriate step to take, because studies have shown that the earlier we can start basic life support, especially the cardiopulmonary resuscitation, as in doing an effective CPR, the earlier we start that, the better the chance of getting the patient back from a position of cardiorespiratory arrest to a point of return of spontaneous circulation. And like I said, it could happen anywhere. It could happen to anybody. This year, we've lost doctors, we've lost politicians, we've lost different kind of people because of respiratory arrest. And instead of somebody trying to bring the patient back, what people were doing is taking pictures them on Snapchat, Instagram, and everybody is just shouting Jesus, Jesus, and not knowing what to do. So we just feel that as an healthcare worker, it is very important for us to be able to know the important step to take. And we'll quickly just run through the step while we'll now do a practical demonstration. And everybody is going to be involved in doing this today. And myself and Dr. Franca will just do a quick demonstration and run through the basic step. We are not here to bore us with stuff, but just to know the basic steps to take and how to go through this process. So, let's have our slide. Dr. Franca, what is basic life?
So basic life support, this refers to the care that healthcare providers and public safety practitioners can provide to patients who are experiencing respiratory arrest, cardiac arrest, or airway obstruction.
So, as she has said, we are talking of patients with either cardiac arrest, respiratory arrest, and what do we mean in summary? We are talking of a patient that has no pulse, a patient that is not breathing, a patient that is having agonal or an irregular kind of breathing. So you are somewhere and somebody suddenly slumps and you cannot get a pulse, or you check the patient whether the patient is breathing, you cannot find any activity. So that is the kind of patient we're saying. When you are in that kind of situation, what are you supposed to do? Are you supposed to pick your phone and record? Are you supposed to call somebody? Are you supposed to be pleading the blood of Jesus? What are we supposed to do? And so we have this case. You are in a bank, and while waiting for your BVN and waiting for your ATM, somebody decides. Our question is, what will you do first? So we want us to take that poll. We just want to know our idea is, what are you supposed to do first? Are you supposed to shout, Yepa, what are you going to do, blood of Jesus? Are you supposed to check for a pulse? Are you supposed to start chest compression immediately? What will be your first action for these patients? So we're waiting. Let's do the poll. Is the question coming up? Okay. Okay.
So,
only 17 people. We can do more. Let's join the poll. We just want to have a sense of what we would do if you are in such a position. What is the first thing to do? And let me also add quickly that many of these things will happen concurrently. But we just want to know, what will be your idea? Will you just be shouting, somebody is down here, please come and carry him, pour water, bring ice block, bring this, bring fan. So ideally, as you will see when we proceed, that the most important thing first is safety. But like I said, most of these things will be happening at the same time. So let's go to the next slide. So what will you do? Like we said, for me, safety, the same must be clear. You should be free from danger, and the patient too should be free from danger. But like we'll see as we're going to be doing multiple things at the same time. We've talked about this a bit, that a patient with respiratory arrest, the patient has a pulse, but the patient is not breathing. And the patient in cardiac arrest, the cessation of cardiac activity, so there is no pulse. So, but the emphasis is not for you to keep looking for this, that you want to make sure that you get a pulse. We don't have that time. Now, whether you get a pulse or not, if you start chest compression, there is nothing wrong with that. So, you should not spend 30 minutes looking for pulse, looking for stethoscope, looking for... So once someone is down, you check. Even if you are not sure whether the pulse is there or not, start your CPR. And the chain of survival is what you do that improves the person's survival. If you are in the hospital, which is the first one up, that starts from your surveillance and recognizing patients that are likely prone to developing cardiorespiratory arrest. We've talked about hypertensive crisis today. We've talked about diabetic emergency. We've talked about patients with CKD. So for those patients, you should know that they have high risk of developing this. So we must monitor them more closely, and we should be prepared to do basic life support. So it starts from recognizing that, and once it's happened, quickly activate your team, start your CPR, followed by defibrillation, then other care. But if it is outside the hospital, where you have an active emergency response, you can call that. But in our environment, what will be your first stop is to call for help, and you start a CPR. And we'll quickly go through the step. So Dr. Franca, let's start. So
like we said earlier, you have to ensure that the area is safe. And how you do that, you ensure that there is no water around the patient or the victim. You ensure that there are no sharp objects, no, if it's an area where there was shooting involved, ensure that you are safe first before you try resuscitating a patient. So that's the first thing you have to think about first.
So that you don't become a victim, and you also don't need to be resuscitated. So you must be safe, and the patient also needs to be safe. And the next step is, like we said, you want to check for responsiveness and pulse and breathing. All these are done simultaneously at the same time. So what you want to do is, this is our patient on the floor. You want to tap the patient and quickly ask. If you know the person's name, you can call. Hello, sir, are you okay? That's you. Are you okay? You want to know whether there is a response or not. Hello, are you okay? And as you are doing that, at the same time, you are trying to feel for a pulse. And as you're doing that, you're trying to feel for a pulse. And what you do is to use the area of carotid pulsation close to you, and with your eyes on the chest and your cheek towards the patient's nose. So you want to see if you can feel whether the patient is breathing, and at the same time looking at the chest of the patient, whether there is chest movement, and at the same time with your finger on the area of carotid pulsation, trying to feel for the pulse. Everything I've said, you should be able to do within 5 seconds, but not more than 10 seconds. And like I said, the aim is not for you to get the carotid pulse and count the carotid pulse. If you cannot feel it, please leave the carotid pulse, leave it alone, and go to the chest and start your chest compression. The chest compression is the most important life-saving thing you want to do for this patient. Because, like we said, the heart has stopped working. No blood is being pumped out of the lung, of the heart to the brain and other major organs. So what you want to do is to do what the heart is doing, trying to pump the heart to be able to supply blood to all those important organs. And time is not on your side. We talked about stroke, we talked about myocardial infarction, that time is muscle, time is brain. Here too, time is life. So you want to check those things, whether there is pulse. If there is pulse and the patient is not breathing, then what the patient has is a respiratory arrest, and the only thing you need to do is to ventilate the patient. We'll talk about that when we get there. But if the patient is not breathing, or you cannot get a pulse, or you are not sure whether the pulse is there, or patient has agonal breathing, or that is not breathing, just assume that that patient has cardiac arrest and starts compression immediately. So let's go through the important step in the important quality of a good chest compression. So we've talked about it, trying to get your carotid pulse. Move to next slide. So start CPR, like I said, is the most critical element. Next slide. So chest compression. So how do you want to do this? Number one, make sure your patient is on a flat hard surface. Effective CPR cannot be done on most of our bed, because as you are applying pressure, the bed is buckling, so you don't have any recoil from the hard surface to compress on. So if you don't have the type of bed where you can put a support under, it is better you take the patient off the bed and put the patient on the floor where you have a hard surface to compress on. And number two, ideally, the whole of your weight should be on the patient. So if you are taller than me in the reverse direction, you may need, and your patient is on the bed, you may need something like a stool so that you will be able to do that comfortably well. Then, the positioning of your hand should be at the middle of the chest towards the lower parts, and put your non-dominant hand on the chest first, then lock the second hand on top with your elbow straight and with the pressure coming from your shoulder, not from your elbow. So we want to do this, lock these two hands and place the heel, not the palm. The heel on the lower part of the sternum. So I have to tiptoe to be able to demonstrate that, and with my hand straight. And you want to push in, you want to push hard and fast to be able to achieve a rate of between 100 to 120 per second. And you want to press in at least about 5 centimeters. And in between, you want to allow a complete recoil. That means you press, you allow the chest to expand, and you continue. So you want to do this and press fast. And like my chief used to say, the easier way to do that is to do a count. So 1,000, 2, 1,000, 3, 1,000. So you count like that, and you allow the chest to recoil. And like I said, the pressure is coming from your shoulder and not the elbow. We don't want to encourage you removing your hand and advancing and do this, but to be able to do this. And you want to, like I said, you want to push hard and fast, achieve between 100 to 120 per minute, and you want to do 30 of that while your assistant, and sorry, when I was calling for help, as you are calling for help, you should give your assistant the instruction, what you want him to do. So, assuming I call Dr. Franca, help. So I'll tell Dr. Franca to go look for an ambu bag and also a defibrillator. I don't know if we have any defibrillator around for us to. So the assistant is not just coming
Can we have a defibrillator?
The assistant is not coming to watch. The assistant is not coming to do WhatsApp or Instagram. The assistant is coming with defibrillator and an ambu bag that we will use for ventilation.
Can we have a defibrillator, please, from the back?
And so but until that person comes, you should continue the CPR. And once your assistant is available, the next thing is for the assistant to try and put the what is it? Ambu bag for ventilation. And how will you position that? Let's show that on our. So it is done by what we call a C and A positioning of the hand. So the C is to be used to apply. The C is to be used to apply the face mask at the ambu bag, sorry, hypoglycemia. The ambu bag to cover the nose and the mouth properly so that there is no allowance for air to escape from the side. Then you have the E. Okay. So I'm used to that. So this is the C to hold this to the mouth and the nose. Then the E is to lift the chin of the patient. So it is better to do the C first, to apply it tightly to cover the nose and the mouth of the patient and prevent any leakage of air from the side. Then you use the E to lift the patient's chin so that the airway is clear. In the past, they used to talk about doing a sweep to remove any obstruction. Please, do not do that. If you see any physical obstruction, you can remove that, but don't do a blind sweep trying to clear the airway. So, like we said, the C, to apply this to cover the nose and the mouth of the patient very well. Then the E, to lift the chin of the patient. And the person do that is going to also be the one to inflate. And you don't want to press more than about 40% of the bag. This bag can contain up to about 1,000 mils of oxygen. So if you push everything, you will cause barotrauma. You just want a gentle press. And at what rate? You do 30 of this, and you do 2 of this. And if you apply this very well, by the time you do this, you will see the chest of the patient moving, which you can see on this. So we're just going to do a demonstration of that. I'm going to be the first responder while I'm going to give Dr. Franca the instruction to be the second responder. So she will be the one doing the ventilation while I will do the compression. And you can also use that opportunity to also change if you're tired. And the second person will also be in charge of using the AED. Like I said, your quality CPR must be with as little interruption as possible. So ventilation is not the business of the person doing the CPR. Let the person doing the ventilation concentrate on that. The person doing the ventilation is also going to be the one applying the pad. You should not, because of this activity, stop chest compression that you are doing, because like we said, it is the most critical element of bringing this patient back to spontaneous circulation. So
let me just add, if somehow there is no ambu bag, continue your chest compressions. Okay? So mouth to mouth is not encouraged, obviously. And there are just a few people that can give mouth to mouth.
Except if it's your spouse.
If it's not your spouse, please. So, but most studies have shown that chest compressions only may be just as effective than, with also ventilation. So if you don't have the ability to do ambu bag, make sure that you continue that chest compression. It works. A lot of patients have come back. A lot, when it is done properly. And as at the last time, we had people that were there from the previous set who attested that after they learned the proper thing, it works. The patient actually comes back. I want you to all just do the C first. Can we do the C together? Do your C first. Then do your E. Do your E separate. Now this C is pressing down while this E is raising up. Can we try it? C press, E raise. C press, E raise. So you are raising up like that. Can you go back to that slide? Show them the slide. Yes. So this is what you are doing. A lot of times, if you don't do this well, you will be putting air into the tummy. Before you know it, if you have been doing CPR for a while, you will see the patient will just vomit, everything to go into the airway. I'm sure, how many of us have seen that before? Confess. I have seen it too. You know. So once you see, you will not say, yeah, he has gone truly. No. If you are not putting the air well, it will go into the tummy will be getting distended. Next thing, everything will come out, enter the airway, block the airway properly and come out. So I want us to learn that very well. We're going to practice it with the mannequins a bit.
So, like we said, going through, so, hello, are you okay? So I'm trying to check for the pulse, look at the chest, help. So, Dr. Franca, please, bring ambu bag and brings AED, and I start my compression.
I hope you can see a green light under the head. That means he's doing it properly. You can see his shoulders are locked. They are straight and locked. This is very critical.
25, 26, 27, 28, 29, 30.
Please don't press the whole thing. Don't press the whole thing. 25, 26, 27, 28, 29, 30. Raise the jaw, raise chin lift. Take your chin lift. Good. Okay, you already done that. Good. So, do we understand that? Is it not easy? It seems easy, Abi. Oh, when you start, I will show you that it's not easy. Okay.
And apply the AED.
So AED is coming now. Don't stop your compression. Say you're looking for AED. Oh yeah, let me put it on. No, don't stop. If you are near the tables, those that have the bags on the tables, near the tables, okay, just stop a bit. Let me just show them something. If you look at your bag, at the back of your ambu bag, how many people have noticed that there's a small tube, a pot that is protruding? Look at the back of your bag. These are our bags. I've seen heaven and hell. You can see. Okay, can you look at the back? Can you see one small pot? You are supposed to connect your oxygen there. If you are in the hospital, you should have oxygen. So you connect one end of the tube to the oxygen and the second end here. You will increase the oxygen flow rate so that this bag fills up with oxygen. So that when you press, you don't have to press the whole bag. Once you press more, 100% oxygen goes into the patient. How many of us have been connecting oxygen here? How many? One. Okay, fine. That's why we are here. So you connect oxygen here, and then it fills up with oxygen. Then you can now give your breath. Do we all understand that? Okay. How many people have AEDs in their hospitals? Yeah. What do we do now? How many people don't have AEDs in their hospital? How many people need me to write to their MCMD? Okay, fine. So it is critical. You should not run the hospital without an AED. It can, God forbid it can be you. God forbid. It can be you, and this can actually change your life. So we have run now. We have come for help. That help is not to call. They have brought the AED. The faster the time to defibrillation, the faster the response. You need a less amount of juice. So what do you do next, sir?
So I will continue the CPR, and while the assistant is applying the AED in between the time that she's also doing the ventilation. So, like I said, you should not stop your CPR because of the pad. So, they will manage to put the pad, the first one under the right clavicle, and the second one mid-axillary line just below the axilla, just around the left nipple. And you continue, you don't stop your CPR, you continue 25, 26, 27, 28, 29, 30.
Please remove the bra. Yes.
Any clothing, all those you have to remove.
There's no point going to the grave with all your dignity. Remove the bra. Okay, as much as possible. I know people have asked a lot of questions. Dry the chest. If it's swimming pool injury, there's a lot of swimming pool. Unfortunately, I happened to be there while they were resuscitating one 6-year-old that drowned. I tried to help, and actually the patient came back. She eventually died, but she came back. The resuscitation was on point. But you have to remember to clean, because if not, this shock that you deliver, it will short circuit. What you will hear is pow. Okay, you should remember that, please.
And so, like we said, the only time you stop your chest compression is for ventilation and when you want the AED to analyze the patient's rhythm. So, I'm doing this. So, she's going to put the AED on.
I don't think the battery is inside yet.
Okay. So, she's going to put the AED on, and like we said, it's automated. Once it is on, it's going to give you instruction of what to do. So, it's going to come on. After coming on, it's going to alert you that it's going to analyze the rhythm, and it's going to tell you to stop. And you stop, you allow the AED to analyze the patient's rhythm. Please, let's show this slide. And if it is a shockable rhythm, it will tell you it's a shockable rhythm preparing to deliver shock. Once it is done with analysis, you still continue your CPR. And when it is ready to deliver the shock, it will tell you, ready to deliver the shock, stay off patient. Then you instruct everybody to stay off. If there is oxygen on, you switch off your oxygen. Please don't forget. Get that. Don't leave the oxygen on. Please do not forget that. And it will deliver the shock, and immediately. If you do this very well, it is energy sapping. You will get tired.
Very.
It cannot be done by, you will get tired. You need a whole team of people so that you can effectively do a qualitative CPR. So that is how the cycle is going to be for a basic life support. And you're going to continue on it until either there's a return of spontaneous circulation, or you get tired, or the scene is no longer safe for you, so that you too, you will not need resuscitation. So, Chief, anything that we've left out?
So, I just want to a lot of us have not done defibrillation before. But when you do the defibrillation, it's not like you do the defibrillation, the person will just come and say, what's up now? It's not like that. So don't shock and then start waiting to see what will happen. Sometimes we do that. We start waiting. How far? Is it happening? No. So immediately you shock, continue your CPR. Remember that you have to wait for another 2-minute cycle before you now auscultate. You now check. Another thing, a lot of us start CPR, then somebody says, check the pupil, is dilated. Oh yeah, let's go. Do people do that? No, the people that do it are not here. It's in the other lecture hall. Yes. Okay, fine. So these are the important points. Pupillary size dilatation is not a marker to end CPR. There are a lot of people with that have come back. Okay, we have seen a lot of people that are walking around today because of successful CPR. Okay, so you can do it and it's very, very effective. Okay, are there any questions, burning questions? Maybe when we start demonstrating, we can now go through a lot of the things. The AED, put it on, and it will do the rest for you. An AED, I think, costs around 500,000. No, it's much now. Dollar has gone up. It's about 1 million, about 1.1 million thereabouts, roughly. You should have one. I think we must have maybe 7 across our hospitals, or 8. Maybe 3, 1 per floor, and all of that.
Please put this slide, please. No, don't stop. So we'll go for demonstration while this is playing. It's just to show.
Call for help.
Call for help.
He has pressed the call bell. Pull the bed down.
Down. He's trying to check for the pulse, the breathing at the same time while waiting for help, and he started CPR. And
if you have a spring bed in your hospital, please try and change it. Okay? Please try and change it. Or get wooden planks under your mattress, because you will need to do CPR. 1 day is 1 day. Then 32. This one will definitely wake him up. Then you can
So
start
see.
setting up the bag. While somebody is putting defibrillator pads, you can see this is a concerted effort. The earlier the better. Don't stop your CPR. If you have a resuscitation trolley, you will notice that there's a sideboard. Another thing you can have wooden boards. When somebody needs CPR, slide it under the patient, a hard board, so that when you are doing the CPR, it actually compresses.
So this is an in-hospital setting, and they've analyzed, it's charging, and we ask everybody to clear before.
Get ready to shock. Then we press shock. Then we continue immediately.
You don't need to wait. Let another person be checking the reading. Let another person be checking whether the patient is back. But the person doing the compression must continue. And
then Oga is coming now. You can see the different scrum. And then you give the rundown before you now go on to ACS. Okay, fine. Straightforward, isn't it? Have we been doing the proper thing? All the patients that have passed through us? Hello? Don't worry. From today, we'll make a convert of you. And some of you that thought you knew, when we start practicing, you will know that let you take heed lest you fall. Okay, fine. I think we can start the demonstration. We are going to have to ration it. The mannequins are extremely expensive. You will see some of them have a light under that will indicate whether you are doing a good CPR. So to bring out a light either under or by the shoulder. So you have to turn back. So you look for the nearest one, and then we will take turns. Look for the nearest one, we will take turns. Please, don't assume you know. Don't assume you know. We will take turns. Can all the Elvis, please come. All the consultants, let's share ourselves. Dr. Anya, Dr. Obi, everybody, let's share ourselves per table. There will be one instructor per table for you. If there is none on your own, just hold on. Some of you can join. You can join this one. Join that one there. There are not many people there. A few of you can join. A few of you can join there. A few of you can join here. Please pick your phones. Put your phones in your pocket. Don't leave it on the table. Your wallet, please put it in your pocket. Don't leave it on the table. We don't know everybody that is here. All right. Please, I need an instructor here. I need an instructor here. More instructors, more instructors. Okay, so we are going to start from the beginning. We assume the patient has stopped breathing. Okay, there are some there. Please, there's a table free here. Some of you can join there. So we have to make do. All right. I think I'll manage this table. All right, Mr. Which name is not a Nigerian name? Agidingbi? Is there anybody like that? No. Adibambambiekun. All right, sir, please. Yes, go ahead. Let's start on our tables. All right, so as you are checking that pulse, you should be looking at the abdomen. So you are checking the breathing and the pulse and the abdomen at the same time. Sorry, let me pass. So what you are doing is this. You're checking the carotid pulse. Then you are putting your head close there and you are looking at the abdomen. So if the abdomen is rising, you will see. If it's breathing, you can also feel it. And then you can feel the carotid pulse. So you have first demonstrated non-responsiveness, then absence of cardiac activity, and absence of breathing activity. Now, sometimes some people are gasping. And some of us say, he never died yet. We'll just be waiting. When he now stops, before we now rush. Gasping is also considered the same as not breathing. So you should start CPR when the patient is gasping. You should check for that, and then you continue. Okay? So let's go ahead. You have finished that. What will you do next? Help. We call for help. Good. Fine. Now go ahead. So, number one, straighten good. Good. Now, you're not bending your elbows. You lock your elbows, and then you push down. Good. Now. Good. Perfect. Make sure there is full recoil. 1,000. Good. Beautiful. Is it red or green? If it's red, it means you're not doing it well enough. It means put your non-dominant hand. If you are right-handed, your left hand should go first, and then your right hand should go on top. If you are right-handed, your left hand should go first, and your right hand should go on top. If you are left-handed, vice versa, so that you are pushing down, elbow straight. Aha. If you do it well, you should not be able to sleep that night very well. Good. 5 centimeters deep is turning red because you are not going deep enough. Good. That's turned green now. Good. Perfect. If you do a good CPR well, there should be some fractures. Yes, there will be some small fractures. So when they do autopsy and they don't see those fractures, they say CPR was not done well or was not done at all. All right, 29, 30. Wait, you move your hand and you're looking at the abdomen. Go ahead. Press 1. Please, it's not like this. There's space here. Put these 2 here, raise it up. Good. And then you press, not completely. Remember, just 40% good. Beautiful. So don't press the whole bag. Like this. Wow. I think so, the leg has. Okay, please. So don't press the bag completely. And don't do it fast like this. You're just going to, it's like you are blowing it. So you press it like this. Can you see that? 1, 2. Once there's heart rhythm, you may just continue the breathing. So if you come and the person is just gasping and you check there's still rhythm, what you can do is you can start 1, 2 after you have put it properly. Okay, let's switch and then let's all of us practice. We'll keep on correcting. Yes, somebody else, go ahead. Start from the anybody. I think bang bang vehicle. Good.
Please, can you get the ample bag and the AED?
So you call for help, call a code blue, call a code. That's too slow. So you must do 100 correct. You can see it has turned green. You must do 100 to 120. The faster you go, the more likely your chance of your patient returning. It saves lives. It works. That's getting too slow. 1, 1,000, 2, 1,000, 3. Count it in your head. 1, 1,000, 25, 26, 27, 28, 29, 30. Move your hand while wait. When you do, you move your hand so that you can look at the abdomen and make sure. Good. There's space there. Can you see there's space here? All your air is going out. So put your C first. Move your hand first. Put your C first. Put down your C. Hold it there. Take your E. Raise it. Good. Now press. 1, 2. Beautiful. You saw it raised up, Abby? Beautiful. Now, next person. Come and do. Put your hand. It's until you do you realize you cannot do it. And the next time you do it, it will be somebody's life. It may be in church. It can be anywhere. It can be on the crusade ground. It can be on campaign ground. Who knows who you resuscitate? That will change your life. You have not locked your fingers good. Are you left-handed? Are you left? Put your left hand first and your right hand on top. Good. Don't straighten your elbows. Straighten your elbows. Beautiful. Beautiful. This man go breaking shoulder. But too fast, there's not enough recoil. Beautiful. That's much better. You can see she's not getting it completely. That's why it's not turning green. So don't be too fast. You need to leave time for recoil. So you press, allow the chest to recoil so that blood can enter the heart. Then you press again. You can see? Aha. Now she has stopped allowing recoil again. So it's not about being too slow, it's about allowing the recoil. Press, allow the recoil. Okay? Okay, yeah, yeah. Please go ahead.
Where you're doing a compression is not the right position.
Okay. So go ahead. If you are a little bit shorter, you need to stand on your toes. You are not pressing, you are rubbing that guy's chest. You need to push it in. Push it 5 centimeters. Good. Beautiful. You can turn green.
That's good.
Good.
Perfect.
It's orange, it means you are not yet doing well.
Yeah.
Good. Perfect. You are doing better. That's much better.
Yeah.
Please come and try it. Or if you don't try, don't think you have seen it. But that's too slow. That's too slow. You want to get 120 per minute. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18, 19, 20, 21, 22, 23, 24, 25, 26, 27, 28, 29, 30. Stop. Allow them to ambu bag. Put your ambu bag. You should have been ready earlier. You need to do exercise, Abi. The patient must come alive. You must be ready. While she's pumping, you get your ambu bag ready. Are you left-handed? Is there anybody teaching here? Okay. Your elbow should be locked, so stand on your toes so that you are directly over. Good, perfect. It's not easy. Don't worry. Well done. It's not as easy as it looks, Abby. Hey, Nurse McQueen, please come and help me here, I beg. Are you left-handed? Put your left hand first. Okay, that's your left hand. Fine. Go ahead. You are rubbing the chest. Good. Better. 4, 5, 6, 7, 8. Beautiful. 25, 26, 27, 28, 29, 30. Raise the jaw. You didn't raise that jaw. Raise the jaw. While you press that side. Beautiful. All right, let's exchange. Somebody else take over. Somebody else take over. Online audience, you can practice with your pillow. That's too hard. That's too hard, McQueen. Soft. 1, 2. Good. It's rising. It's rising. Now it's doing well. You can see. It's rising. Next set. Color code. Code blue. Make sure you practice. Don't just stand. Everybody, if you have done before, move. Next person do. You must practice. Don't look at it. It's not as easy as it looks. Yes, why not? Nope. So, as much as possible, try and move the patient close to you. Good. Good. You need to allow the air there to recoil. 1, 2, 3, faster. 5, 6, 7, 8, 9, 10. Beautiful. I like how your shoulders are. You have not started. You have not reached 30. You have not reached 30. Make sure has that. Oh yeah? Oh yeah, go ahead, do your. While she's doing that, you be preparing your arm. Don't wait for her to finish before you start setting your elbow back. Continue. You are still doing. Be setting now while she's doing. Be setting. While somebody else is bringing AED. So please remember this, your C. Put your C first. You have pressed it now against. Yes. So this is C. Press the C first against the mouth. Then now put the E under your distance. Then while still pressing. Good. Now press. 1, 2. Beautiful. Yeah, you keep your eyes there to see that it is lifting. You are not going down enough. Good. Beautiful. Why are you cutting the Okay, somebody else should come and do. If you have any question, please ask. Oh. When you're not starting is beta blockers, and then you start the other ones as much as the blood pressure can carry. So if somebody comes with heart failure and is 170, you can't start all. You start your fusemide, your spironolactone, you still start ARB. If you don't start ARB, the patient is not living that way. So you start that one or AC inhibitor. You start, even if it's 2.5, even if it's 1.25 milligrams, you must start something. The other patient will never live. Once that has started, if you are doing well, the blood pressure will start going up because the heart is getting better. Then you cannot increase the dose a bit. It gets better, then you can introduce another one. It gets better, then you introduce another one. So like that, you're introducing. That is as patients. Even if it is 90-60 onset, we will still put. Because if you don't get it in, that patient is not getting better. So that's what the only thing is that beta blocker you wait when it is drier, less breathless, then you can start. But sometimes even then you still start small because sometimes you may never be able to get them out without adding it in. Yes, but don't give too much because you don't want to bring down sodium too much. So loop, fusemide for example, 28 hourly, put on there like 28 hourly, you start with, check the weight daily, start your AC before, our doctor will be there. Remember that fusemide does not affect life. Patients will still die. The dioxin does not affect life, patients will still die. Without spironolactone, AC inhibitor, SGLT2, beta blockers, those are the only ones that can prolong life. That fusemide, the patient will bless you, but they are still going to die. It doesn't change anything about their death. It just makes them feel better. So the earlier you can put them in, sometimes some people don't even start the fusemide. They start those ones because, so you give the fusemide. So will those ones help with symptom relief? Not much. Yeah. But eventually they will. If you give fusemide alone, you will never get that person out. In fact, they will be there in your bed, they will be coming every day, they will be fixing you. If you cannot introduce those ones, you cannot survive that person cannot survive. 3 weeks, 6 weeks, they are done. 6 months. Please try the ambu bag. It's very hard. Put your C first, then your E next. Make sure you attempt. Don't stand and look. Has everybody attempted here? When do you stop? You stop when the patient wakes up. You stop when you are tired. You stop when the place becomes unsafe, the relationship wants to kill you. You stop again, when again? Sometimes you have done continuously. Typically, we wait 20 to 30 minutes of doing continuously. And you have shocked, you have gone to ACLS. ACLS will go in tomorrow to the more details. This is basic. There are extras that we do that work. So you do those extras and the patient comes back. So you continue. There are people that we have done 30 minutes and they came back still. There's no limit. There's no limit. As long as the AED says shock, you continue shocking. As long as it says shock, it means there's still heart activity. You continue shocking till you can finish what is necessary. Okay? But the AED, after a while, starts telling you no shock advised. So when there's no shock advised and it's asystole, then if you continue for under 30 minutes or so, or 20 minutes of asystole, then you can stop. But apart from that, please continue. Shock, 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 shock. Bring in your other ones. Now, the other ones we'll talk about tomorrow. When you bring adrenaline, amiodarone, adenosine, atropine, bringing all those ones in. That is advanced. You know, bicarbonate and the like. Camera crew, have you tried yourself? That's too slow. You are just rubbing the man. That's too slow. 1, 2, 3, 4. Forget the lights. That's too slow. That's too slow. 5. Faster. Good. Perfect. You can see it's now 2 lights. Beautiful. You're not going too fast. Good. You want to be around 100 to 120. There are less people that will come back from 60 to 70. The peak in the studies is 100 to 120. People that get to 120, they typically get to come back. If you don't get there, they may not come back. You can't call anybody back from heaven like this, so. Yeah. Or you have to do the ambu bag. Make sure you practice all of them. The next time you are going to be doing it, will be on a patient. Some of us will not do this again for another 20 years, but it may be somebody that you love. The reason why you must tap and ask, so that you don't start pressing somebody that is sleeping. Have you practiced, sir? Are you left-handed? Which one? I don't know which one. No, which one are you left-handed or right-handed? Okay, put your left hand in front. Good, go ahead. Your elbows should be straight. Good. Beautiful. 5, 6, 7, 8, 9, 10, 11, 12. You are getting to 30. We know those are not doing exercise now. 19, 20, 21, 22, 23, 24, 25, 26, 27, 28, 29, 30. Don't press the entire bag and you are over raising. See space. Press the C first. Press the C first. Are you pressing it? Now raise it while you are still pressing. Perfect. Now press. 1, 2. Okay, good. Then somebody else continue. Every 2 minutes you must switch your ambu bag, your compression, because that person will be tired. Hey, Mr. Man, your hand is bending, oh. Your hand is bending, oh. Good.
The bags, they've compressed.
Okay, beautiful. Is there anybody that has not compressed or bagged? Is there anybody that has not compressed or bagged? Please come to this front table where Dr. Ludivia is. There is space in the front if you have not bagged and compressed. Come under scrutiny. Let us see what you are doing wrong so that we can correct you. Please. That is the reason why we are here. That is the reason why we are here. Patients must survive. All right. All right, we'll be ending now. Can we just have our seats as we close? Can we have our seats for one announcement as we close? And then we'll take any final questions. Can we have our seats as we take a final announcement and we close? Any burning questions we can take now? Tomorrow we are starting by 8:30. Please be here on time. Please be here on time. And tomorrow we have ACLS. This was basic. We are going to go advanced tomorrow. So tomorrow you need to come with your mind here. We are going to look at the different ECGs, the different drugs, and what you will give. And I will show you a case that we have done. The man is walking around today. Hello? Hello, can we just... One minute, let's close before we stop, please. Stop, please. We'll continue after. The ambulance are still here. Stop, please. Just 1 minute as we close. Thank you so much for coming today. I believe it has been valuable for your time. Tomorrow, we are going to do ECG in 90 minutes. We are going to try and go through stroke. Stroke will happen first in the morning. We'll have ECG. Then we are going to have advanced cardiac life support. So for the advanced cardiac life support, it demands that you can read an ECG. If you cannot read an ECG, you will not be able to resuscitate that patient completely. Now, in cardio care and most of our practice, we have successfully brought back a lot of people, so it works. Even today's own, this one you have learned today, if you do it well, you will see that your next patient that they call you for will likely come back to life. Okay, so far it's not end-stage cancer or something like that. So this is critical. So if a patient collapses near you, you should coordinate people to do the correct thing. If you cannot ventilate, continue compression till your AED comes. Continue compression till your AED comes. For those of us that are a little bit well-to-do, let us try and get some money and donate an AED to our churches and our mosques. A gathering of 1,000 people should not happen without an AED nearby. Even event centers should have an AED. There should be a law. Maybe we should move for that in the House of Assembly. Okay? So tomorrow, 8:30, please try and come on time. We will start exactly at the time. If you are here, if you are late, you have missed it. And there's nothing we can do about that. When you are posting your pictures, please hashtag ACS 2022 and hashtag CardioCare. We thank you very much for coming, and we'll see you tomorrow. Have a nice night, and see you tomorrow. Please snap pictures outside and hashtag ACS 2022, hashtag CardioCare. See you tomorrow, 8:30 sharp. We start off. If you have any questions, you can meet any of the facilitators at the front. All the consultants are at the front. You can ask questions. If you have any questions, please meet any facilitator.
Jiggy. No, no. Oh, no, 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 no. Bada. Ula.